Hello, Arun sir.
हेलो। हाँ जी। ठीक है, ठीक है। यस, या 10:30, ओके।
A very, very good morning to all. Can you please hear me?
Yes, sir. Good morning.
Yes, sir. Good morning.
Am I
Very good
audible?
morning, sir.
Yes.
Anyone can respond, please?
Yes.
Yes,
You're
sir, we
audible.
can hear you very well, sir.
Yes, can you hear me?
Yes, sir.
Yes, sir. Very well.
All right. Thank you so much. Thank you.
Yes, sir.
So let's begin. Let's begin with the session. Uh, because there were some technical issues, and we had to switch over to different platform. Now it has been resolved. Expert for the day, Dr. Rakesh Kumar, he has joined. First of all, let me introduce to you the speaker of the day, the expert for the day, Dr. Rakesh Kumar. Dr. Rakesh, he's a leading pediatric endocrinologist of the country, and he's serving the society in a big way, helping the patients and their families who are facing this problem of type 1 diabetes. So we are really privileged to have Dr. Rakesh Kumar in our program, and he's going to share with you the issues related to type 1 diabetes. And this is going to be a sort of a, you can take it to be a session through which a lot of awareness would be generated, because many of us are not aware of the problems the children and their parents are facing with respect to the management of type 1 diabetes. Largely, we are familiar with type 2 diabetes only, which happens to elderly people. And Dr. Rakesh Kumar, he's doing a great job by helping the children and their families to manage this problem. And he'll be talking about and NIT Jalandhar, and really is really privileged to be associated with Dr. Rakesh Kumar. We have started working together in this domain, and we intend to make use of gamification to address this challenge. And Dr. Rakesh Kumar, he'll be sharing with you the type 1 diabetes, what are the issues, what are the challenges. So Dr. Rakesh Kumar, as I shared with you, he's a professor uh, of pediatric and endocrinology in Department of Pediatrics, PGI, Chandigarh. And he has done his MD Pediatrics from Medical College BHU, Banaras Hindu University, and he has been a fellow of Pediatric Endocrinology, Manchester, UK. Yeah, his work has been widely recognized. He has done a lot of projects in this area, in this domain, within India as well as abroad. And and it's really a great opportunity to get connected with Dr. Rakesh Kumar. Thank you, Dr. Rakesh, for accepting our invitation and being part of this program. So I'll request Dr. Rakesh to please start with his presentation. Dr. Rakesh, can you hear me? हाँ जी डॉक्टर साहब, कैन यू हेयर मी? अभी गूगल मीट पे अच्छा, यू स्टार्ट विद योर प्रेजेंटेशन. नहीं नहीं, यू स्टार्ट विद योर प्रेजेंटेशन. हाँ जी, मैंने इंट्रोड्यूस कर दिया. हाँ जी. Yeah, people are joining. Right now, there are 55 participants. They'll keep on joining. I'll keep them admitting. वो चलता रहेगा. हाँ जी. Yeah, you start making presentation. आप please speak. Maybe नीचे नीचे से होता है ना वो icons जो आते हैं. You have to turn on your microphone. By default off होता है शायद. नहीं नहीं, उस पे नहीं आ रहा. स्क्रीन आ रहा है. यस. जब आप नीचे जाते हैं स्क्रीन पे तो वो पॉपअप हो जाता है ना, जहां से आप प्रेजेंट करते हैं. नहीं
सर,
नहीं,
सबका माइक्रोफोन तो ऑन है सर.
नहीं वॉइस नहीं आ रहा सर आपका. आप एक बार सर लॉग ऑफ करके ना दोबारा ज्वाइन करिए. प्रोबेबली दैट विल वर्क. नहीं.
सर ईयरफोन्स प्लग इन करो, फिर होगा.
Okay, now it should be fine.
Yes, yes, audible. Done.
Okay.
Thank you.
All right, so we'll start now. Okay, I hope I'm audible now. Could someone respond, please?
Yes, sir.
Yes, sir, you are.
Please go
Okay,
ahead.
thank you.
Yes, sir. Very much clear now.
Okay, if everyone can mute now, please. Yeah. First of all, good morning to all of you, and sincere apologies for this delay. I think to cover up the time, we'll straight away start with the job. So I'm Dr. Rakesh. You must have already been told about and introduced. So I'm a pediatrician, basically a child specialist with a further specialization in pediatric endocrinology. Endocrinology is a field which deals with problems of hormones in our body, and usually you would know is thyroid hormone, insulin hormone, growth hormone. There are some more hormones, sex hormones. So problems or imbalance of these hormones can lead to many diseases, and this particular area is covered by endocrinologists. So pediatric endocrinologists, as you can understand, the endocrine problems in the pediatric age group, which usually covers till 14 years or even sometimes 18 years of age. So diabetes, which you would know or would be knowing till now, is basically the disease of the adults, and it is called type 2 diabetes actually. So diabetes just means increased blood sugar in the blood, and it is further of many types. The most common type, or around 90% of patients of diabetes are basically type 2 diabetes, and they start having diabetes after say 40 or 50 or so. And this is the most common type of diabetes. Around 8 to 10% of all diabetics are actually type 1 diabetes. So type 1 diabetes is another form of diabetes which actually starts usually in childhood. Almost 70 to 80% of all diabetes, type 1 diabetes, would start actually in below 18 years of age or below 20 years of age. So diabetes do occur in children, and it is type 1 diabetes. And this is different from type 2 diabetes in treatment as well. The cause of type 1 diabetes is basically the deficiency of insulin hormone. Insulin hormone is a hormone which controls our blood sugar. It lowers our blood sugar. How does it lower our blood sugar? This figure would help me explain this to you. So whatever we eat in the food, it reaches the stomach. So most of our food or majority of our food is actually made up of carbohydrates, and these carbohydrates are the main source of sugar or glucose in the blood. So in layman terms, it's sugar in the blood. In medical terms or in technical terms, it's glucose. There are different types of sugars, as you would know from the science background. But the main sugar helping our body or running in our blood is glucose. So all these carbohydrates in the food is actually broken down into glucose, and this glucose then runs in the blood and supplies to whole of the organs of the body. Each cell or tissue of the body is supplied by this glucose. Why is this glucose required? Glucose is the main source of energy for all the cells in the body, or in other words, it's main source of energy for our body. It's similar to what petrol is for. Sorry. Hello.
Slides नहीं है.
Sorry. A slide.
Slides का presentation होता है.
Okay. Okay. I'll just check if you can just hold on. So are the slides visible now?
Yes, now it is visible, sir.
Okay. Thank you.
sir. Visible.
So finally everything has started now. Okay. Thank you. All right. So I was explaining this to you. Whatever we eat, it reaches our stomach. This is the source of sugar in the blood or glucose, and the carbs in the food are broken down into glucose or sugar, which runs in the blood, and this glucose is supplied to all the cells in the body. Another source of glucose or sugar in our blood is liver. The liver is also called storehouse for the glucose. So whatever we eat, we obviously don't eat 24 hours. Whatever we eat, some part of it is actually stored in the liver to be supplied to the body when we are not eating or when we are fasting for number of hours, as in night. So there are two sources of sugar in our blood. One is the food and second is the liver. So this glucose runs in the blood and is supplied to all the cells in the body for the cells to work properly, because this sugar or glucose is the main energy for all cells to work. And what is the role of insulin here? There is an insulin bridge, basically you can say, which has to be crossed before this glucose enters the cells. So this bridge is only open when there is sufficient amount of insulin in the body. So it is called insulin bridge. So insulin is secreted by another organ which is just below the stomach in our abdomen, called pancreas. So in the pancreas there is a sensor system. This figure will help explain this. This is the cell of our pancreas which actually secretes insulin. So whenever there is glucose, it is sensed by this beta cell. When there is excess glucose, this cycle of chain reactions start, and there is a potassium channel which gets depolarized, and then there is influx of calcium, and which stimulates secretion of insulin into the blood. So this is the basic mechanism in the beta cell. Beta cell is a cell which is present in the pancreas. So this beta cell is the main source of problem in type 1 diabetes. These beta cells are somehow damaged in patients with type 1 diabetes. So to summarize, in type 1 diabetes, there is pancreatic beta cell damage, which leads on to decreased release of insulin. And this decreased release of insulin means that no glucose is entering the cells and whole of the glucose is in the blood rather than going to the cells. So further, this is how it happens in the diabetes. Pancreas is not able to secrete the insulin. This is the pancreas here. And this blue track is the insulin, or blue dots are the insulin. And light or greenish dots are the insulins and blue dots are the glucose. So whatever our stomach converts glucose, this enters into the bloodstream, these blue circles, and pancreas produces little insulin or decreased insulin in type 1 diabetes. So this ratio of insulin to glucose is markedly decreased, and most of the glucose does not enter the cells. Only the insulin and glucose in pair would enter the cell. So most of the glucose remains in the blood. And so there is high blood glucose called diabetes. In type 2 diabetes, this pancreas is all right. Insulin secretion is also all right. Type 2 diabetes, the diabetes which occurs in the adults. However, the insulin action at the cellular level, in the peripheral level, is not proper. Somehow insulin is there, but it is not able to open that bridge or door for entry of glucose into the cells. So that there is a problem of receptors at the cellular level. So insulin sensitivity is decreased. That is type 2 diabetes. So in type 1 diabetes, when insulin is deficient, we have to replace it with the external insulin. So that is the main treatment. So just to explain a bit more the symptoms which occur with this diabetes. So because there is a lot of sugar in the blood, it goes to the urine. So a patient passes a lot of sugar in the urine and he has to pass a lot of urine as well to pass that sugar out of the body. So there is a lot of urine formation. We call it polyuria. Then there is, because of polyuria, patient has a lot of thirst because a lot of water is lost in the urine. So a lot of thirst is there. We call it polydipsia. And because cells are not getting their energy, so there is hungry cell and energy level in the body significantly reduces and patient feels tired, lethargic, and when it is severe, patient is bedridden to that extent. And if brain is also affected, patient can go into altered sensorium, loss of consciousness, and acute complication of diabetes can occur called diabetic ketoacidosis. I won't go more details of that. So that is the basic pathology in type 1 diabetes. Again, I am retreating. Type 1 diabetes is insulin deficiency and type 2 diabetes is insulin receptor level problems. Insulin sensitivity is decreased, but insulin sufficient amount is there. So normally what happens with each, so what is the role of insulin? Basically to remove glucose from the blood and make it enter into the cells. So that the blood level of glucose remains almost in a definite range. It remains somewhere between 70 to 120. If there is more glucose coming, particularly after the meals, the insulin amount will also increase, insulin secretion will increase, and more of the glucose will enter the cells. And a upper level of 120 is always maintained. So body will adapt accordingly. If glucose increases, whenever we eat something extra, glucose in the blood increases. At the same time, insulin also secretion increases and the upper level of the blood sugar remains around 120, 140, not more than that. Similarly, in the night when we are not eating at all, so insulin secretion decreases so that minimal level of glucose in the blood remains around 70 and not less than that. So this narrow range of 70 to 120 is maintained because pancreas is secreting insulin as per the body's requirement. When this pancreas stops functioning, you can understand that insulin has to be provided from external sources in form of injections. Unfortunately, there are no tablets of insulin because it is a peptide hormone even if we take it orally, it gets broken up in the stomach because of the stomach acids, and insulin does not reach the blood. So the insulin, if we are giving it from outside, it has to be given only in form of injections. So we have to give subcutaneous injections of insulin. So we have to provide insulin 24 hours. You can understand that insulin is required 24 hours. Even when we are not eating, our body still requires glucose and energy. Even when we are sleeping, our body requires, some of our body parts are actually still working even while we are sleeping. So even in the night, we need some insulin. And that insulin is called basal insulin. When we are not eating, the insulin amount required, minimum amount, is called basal insulin. And when we are eating, these are the 3 spikes for 3 meals. So when we are eating, the insulin secretion increases because blood glucose rises with every meal, after every meal for around 2 to 3 hours. And our pancreas secrete extra insulin for those 2 to 3 hours, depending on level of glucose increasing, and which obviously depends on how much we are eating and what we are eating, how many sugars or sweet foods. Similarly, this is the peak or spike for the lunch and then for the dinner. And in between, if we take some snacks, again, there will be smaller spikes because we are taking smaller meals. So this is how normally blood sugar is maintained within that range of 70 to 120. But you can understand when pancreas is not working, this glucose level can increase to any extent. We do get patients who are diagnosed for the first time, their sugar rising up to 500, 600 because they are eating, but insulin is not around. So that sugar go on increasing in the blood. But you can understand at the level of the cells, the glucose is low. Cells are not getting that glucose. That glucose is not being utilized where it should be. And all the glucose remains in the blood. It either passes in the urine or it go on increasing in the blood. But cells are not getting that glucose because there is no insulin which would put that glucose from blood into the cells. So this is the primary problem in patients with type 1 diabetes or insulin dependent diabetes. Earlier, this type 1 diabetes were also called as insulin dependent diabetes because these patients are dependent on insulin for their life. And this insulin has to be provided lifelong. So that is to be understood that this insulin has to be provided lifelong because we have to control sugar lifelong and 24 hours a day. And further, this type 1 will not change into type 2 when a child grows up. So once this starts, it is a lifelong disease and it is a lifelong deficiency of insulin because that pancreas, once it stops working, it does not work throughout life. So that organ is gone. So insulin has to be provided lifelong, 24 hours a day, and there are different insulins available. So there are different insulins available for this purpose to supply the insulin as per the requirement of a person. You can understand that how many times a person is eating, we will have to supply insulin accordingly. Okay. So for meal insulin, when we are taking a meal, when blood sugar rises acutely, so we have to provide short-acting insulin. So whenever we eat, sugar normally increases for around 3 to 4 hours, depending on what type of food we are eating. If it is simple glucose drink or a cold drink, soft drink, or a fruit juice, the glucose will increase sharply because it does not have to be digested much. So it straight away converts into glucose and goes into the blood in next 15 to 20 minutes or 1 hour, and all the glucose is utilized in an hour or so. If we are taking something fatty, it will take 4 to 5 hours for the digestion and glucose to enter the blood. But the normal food which we eat, roti, chawal, sabzi, so this type of food the glucose starts increasing after around half an hour to 45 minutes in the blood, and peak reaches at around 2 hours, and its glucose is over by around 3 hours. So for a normal food, we need more insulin for around 3 hours. So for each meal, we have to provide extra insulin injection, and this we call it as meal insulin, or it is also called as bolus insulin. We just give a bolus of insulin dose before every meal. So at least 3 meals we have to take, and we have to give at least 3 meal injections. And you can understand this injection has to be given before the meal, because insulin also takes some time after the action to reach in the blood. After the injection, it takes some time to reach in the blood. So for the meal insulin, there are 3 options for us. Inhaled insulin is still in the experimental stage. It's relatively costly. It's available in the US, but not in India as yet. Rapid acting insulin injection is available. It works for around 3 hours. Peak is at around 1.5 to 2 hours. Then there is another regular insulin which works for around 6 hours or so. Then these are the insulins which work for around 12 hours to 24 hours and even 36 hours. These insulins are actually used as basal insulin. The insulins which are not for meal, but basically for the basal requirement of insulin without taking any meal. And these insulins, short-acting insulins, are basically used for pre-meal injections. So there are 2 types of insulin which have to be used in the same patient. One will work as basal insulin. These are Detamir, Glargine, and Degludec. And others will work basically rapid-acting insulin or regular insulin, and will work as bolus injections. And with this, we try to achieve something like what happens normally, that there is a background insulin always in the body, which is fulfilled by any of these insulins. And before each meal, we provide this insulin as normally occurs because of the glucose surge in the body after every meal. So coming to the clinical management, how do we actually treat them? So we teach them actually, these patients, as you can understand, because they will require at least 4 injections in the day. 1 injection is basically for the background insulin, which works for around 24 hours, and at least 3 injections for the 3 meals. But you can understand in children, they eat more than 3 times. They eat number of times. They have a school tiffin also. So actually all the meals or even the smaller snacks should be covered with insulin. Otherwise that snack will not help much. Whatever glucose is there from that food, it will not be utilized properly if we don't have sufficient insulin with that snack or meal. So it has to be provided ideally with all the meals or snack, the insulin. So they have to be taught how to give insulin injection number of times in a day, where to give, how to do it. And then they also have to check the blood sugar before giving insulin. If blood sugar is already high, we have to give more dose. And before giving insulin, if blood sugar is on lower side, maybe we have to decrease the dose. So giving the dose of insulin is decided by number of factors. 1, how much we are eating at that particular time. 2, how much sugar is already there in the blood. What is the sugar level in the blood, which we check with the glucometers. Many of you would have seen elders in the family who have diabetes checking their sugar with the finger prick to see what is the level of sugar at that particular moment. And this level actually fluctuates. It changes 24 hours a day. Every 5-10 minutes the sugar level will change. So it's not like कि सुबह जो चेक किया था वही दोपहर को होगा वही शाम को, ऐसा नहीं है. So sugar levels fluctuate. So we have to check before every insulin dose. If sugar level is say 300, we will have to give some extra insulin. If sugar level is say 70, maybe we'll have to slightly decrease the insulin dose. So sugar testing, insulin injection, then calculating how much meal we are eating. So how would we calculate that? Why we need to calculate that meal? Because we need to roughly estimate how much glucose will be generated in the body with that particular meal. So we call it carb counting. The meals, carbohydrates are actually counted. We call it carb counting. So there are actually, it's similar to how we count the currency or money. So it has to be learned. It doesn't take more than 15 days to 1 month if someone wants to really learn it. So roughly one roti is around 15 gram of carbs, and it will increase around 50 milligram of blood sugar in the blood. So this is a common example we give. So usually in the packed foods or in the juices or in the cans, in the cold drink wrappers, they will have written how much carb is there in that particular, say 100 ml of that particular juice or drink. And even all the biscuit packets, so everything will have a carb count written on them. So which is always good to count before we eat it for these children, for these patients, and accordingly they can adjust their insulin dose. So carb counting has to be done. Then another factor which will decide the dose of insulin is how much activity we are going to do in next 3-4 hours. Whether someone is going to sleep, whether someone is going to play a football game, whether someone is going to sit and study. So we have to take that also in account, because aggressive exercise will again lower the blood sugar level. So we may have to decrease the dose a bit, and sleeping may increase slightly the blood sugar level. We may have to, because there is no activity, so sugar will not be utilized. So insulin dose may have to be slightly increased. So all these things are actually taught to these parents or these patients. It takes around at least 4 or 5 sessions with them on daily basis. So we have a structured teaching module for them. We have PowerPoint presentations, and we call it diabetes self-management education. So it is done in a structured manner by our diabetes educators, nurses. So what we teach them basically is that sugar control is like a 4-legged table. The sugar control is the top of this table, and it can remain stable only if all the 4 legs are strong and good and are being maintained properly, like insulin injection doses, sugar monitoring, and then monitoring with the doctors every 3 months or so. Then proper diet plan. Diet plan here would mean that counting of carbs. How we have to count the meal and accordingly adjust the dose. Then activity and exercise has also to be considered. So these are the 4 important legs of the sugar control table. So if any of the legs is weaker, this table or this blood glucose control is not going to be good. So we as a doctors basically write the best possible insulin injections, best possible insulin available. They can check sugars regularly with the glucometer. But if someone is not compliant with the diet, a child is eating whatever and wherever he wants without any injections, then there is a lot of problem. Then there is no plan of the activity as well. We are not adjusting doses for the activity, or we are not taking extra carb for the aggressive activity, so low sugars can occur. So both high and low can occur, particularly high with the eating extra snacks and low with extra activity. Even if we are giving insulin properly and monitoring sugars properly. So if we are not doing well with these 2 legs, so again sugar control will be haywire. On top, and this table stands basically on firm grounding of diabetes self-management education. They need to know how to adjust all these 4 legs, or insulin therapy, monitoring, dietary plan, and activity. So this knowledge is very important for them to manage sugar control properly. And then there are more accessories to it. We can make this table look even more beautiful, or this sugar control can be even very finer with other accessories, and that accessory is what we call technology, use of technology, and this is what we are discussing or will be discussing today. Technology, how can technology help here? The repeated injections can be provided with insulin pumps which are available. I'll be discussing about them. This sugar monitoring can be done with continuous glucose monitor, in short called CGM. Continuous glucose monitors. I'll be discussing how they work. Then obviously knowledge of type 1 diabetes, again technology can help in that. Okay. So coming to insulin therapy, I think most of it I have already covered. This is the standard regimen which we use called basal bolus regimen. I have already explained what is basal insulin, what is bolus insulin. These 3 blue colored peaks are basically the bolus insulin, which are given before every meal, breakfast, lunch, and dinner. And this green one is the basal insulin, which is provided by one of the long-acting insulins, glargine, detamir, or even degludec is available now. So the same thing can be achieved with the insulin pump as well. Here we are using injections and child has to be pricked every time for breakfast, for lunch, for dinner. Insulin injection has to be given either with the insulin pen or with the insulin syringe. So needle prick has to be there every time. So at least 4 needle pricks in a day for insulin injection. And before every injection, sugar has to be checked. How much is it? So 4 another needle pricks in the finger for checking how much is the sugar. So you can understand the problem of these kids or these patients who have to undergo at least 8 needle pricks daily, lifelong, to sustain their health and to control their blood glucose. And still, so because of this, it's a very stressful regimen. They need lot of psychological support, social support, and all this obviously involves a lot of cost as well. So cost of this treatment, standard treatment of basal bolus injections, 4 injections per day plus glucose testing 4 times per day is around 4,000 to 5,000 per month for average child. It also depends on how much dose is required, but still it depends on the cost is around 4,000 to 5,000. You would understand that dose for insulin varies from child to child. Then from meal to meal, in the morning, the dose would be something different. We call this dose is actually calculated in insulin units. We call it units. So how much units? 10 units, 4 units. So how much units are required for the breakfast? How much for the lunch? How much for the dinner? So we as a doctor cannot calculate the dose for each child. We can calculate the starting dose. But on daily basis, because on daily basis sugar is fluctuating, the meals are different, times of the meals are different. So on daily basis, parents have to decide how much dose has to be adjusted. Activity is different, sleeping pattern is different. So because of all these factors, sugar changes, sugar level in the blood changes. So we have to change the insulin dose accordingly. So here comes the role of some sort of intelligence or some sort of technology which can guide them how much dose is required for a particular time of exercise, for a particular amount of carbs, for a particular sugar level in the blood at that particular moment. So considering these 3-4 points, if someone can guide them correctly how much dose is to be given, so that would be a great help for these patients. Otherwise, most of these patients who are not obviously literate, they would be literate otherwise, but not about the diabetes treatment. They are not doctors, obviously. So it is difficult for them to understand, and they repeatedly make mistakes. They have to make decisions number of times in a day, at least 8, 9, 10 times. When sugar gets low, they have to take some decision. When sugar is high, again, they have to take some decision. What action has to be done? Before every meal, they have to take some decision. So they have to decide the insulin dose and number of other actions on daily basis a number of times, and that decision making actually goes haywire when they are not aware properly, when they are not sincere, when they are not doing things properly. So they need support, and technology obviously can be a great support, and artificial intelligence, machine learning, which we call, can help. Then serious gaming, how can that help? So you can understand that this regimen has to be followed daily, 24 hours, 24/7 for lifelong. So anyone can get stressed out and get apathetic towards this treatment or get tired, burnt out. So motivation is lost. Many patients, particularly our adolescents, young adults, they get psychologically upset. They stop taking treatment. So motivation is very important, and that serious gaming would be an important motivating factor, and keeping them involved with rewards and number of things, which are the strategies applied for gamification. So coming to technology in this management, Basically, this is insulin pump. This is how it looks like. There are different types available. At least in the abroad. In India, we have only one right now, one company supplying insulin pumps. So insulin pump, basically, it's nothing but an injecting device. Insulin is the same. It is filled in this reservoir. It is fit into this pump. And there is a sort of rotary pump sort of thing which pushes this insulin slowly through this tubing into the body and injects it slowly 24 hours. So it gives background insulin 24 hours. And we have to press few buttons and tell the pump how much units are to be injected at a particular meal time. So what is advantage of this? That once we fix it here, this needle, we don't have to prick again and again. That is the main advantage, but particularly for the patients. For doctors, for us, the main advantage is the better way of giving insulin. It is more like pancreas. It provides low dose of insulin 24 hours. We can adjust that dose on hourly basis, that we want less dose in the night. We want, maybe we want slightly more dose in the early morning because of early morning hyperglycemia, which is normally there. And then for multiple meals, we can provide insulin for multiple meals. With the insulin injections with the pen or syringe, we were giving maximum 3 injections. But with the pump, when we have to just press the button, we can give at least 3 more, or maybe all the snacks can be covered. So we can give multiple insulin boluses when we are using pump. So you can understand that it is convenient. It is just that it has to be fixed here. And this insulin cannula, it is a plastic needle basically. It doesn't have any issues while it is on. It is very easy to insert. Patient can himself do it, and it has to be changed every 72 hours because it gets obstructed here. It stops working. So every 72 hours it has to be changed. It does not disturb with the routine activities like sleeping, bathing, running, exercising. It can easily be done with this on. For bathing, we can just remove it from here. We don't have to remove the cannula. We just detach this tubing, and this pump can be kept aside while changing clothes, while taking bath, etc. So this is a very commonly used technology, at least in the abroad. Around 70% of patients, children particularly, are using this insulin pump because it is very convenient. We can provide more insulin doses and more physiological, more like whatever pancreas does. And glucose control is better, and there are no needle pricks, extra needle pricks. So this is obviously useful and better. I think I won't cover this for the sake of time. So insulin dose adjustment is important thing on daily basis. Basically, they have to monitor sugars for at least 4 times before each meal and then inject insulin. And when they see that, suppose daily pre-lunch, their sugars are high, that means that previous dose which was provided was not optimum. So they have to adjust that morning pre-breakfast dose. Similarly, if evening sugars daily are high, it means the previous dose which was given was not sufficient. So that dose has to be increased. Similarly, if the sugars are low at that any particular time, the previous insulin dose has to be decreased. It's very simple to understand. Anytime sugar is low, the previous insulin dose is to be decreased. Means that insulin dose was more effective, more than required. So sugar has gone low. Similarly, if it has gone high, the previous insulin dose was less, so it has to be increased. So this adjustment, we call it as titration of the dose. So pre-breakfast sugars, we have to adjust the previous dose, which is usually the long-acting insulin, the basal insulin. Pre-breakfast, we haven't taken previous meal. That was dinner only, and for that we had given this dinner shot of insulin. So for pre-breakfast, it is a 24-hour insulin which has to be adjusted. And for pre-lunch, pre-dinner and bedtime, because just within last 2, 3, 4 hours the meal was taken, so that particular injection has to be adjusted accordingly. So all these basic rules can be incorporated into some sort of machine learning and technically algorithm can be generated. So this is what actually pump is also using, and artificial intelligence again, that what are the daily sugar records, what are the daily trends of the sugar records. Using those trends, basically the machine can learn and advise what adjustment should be done for the next dose or over the next few days. So we ask them to basically maintain the record of these. So this is how they maintain it. So they have to write, this is the date here, they have to write pre-breakfast sugar and how much insulin units were given. Actually, they should be checking 2 hours post-breakfast also, just to accurately see how much units were sufficient. Then pre-lunch sugar and pre-lunch insulin dose. Similarly, pre-dinner sugar and pre-dinner insulin dose. And this is a bedtime basal insulin or long-acting insulin. And first few days basically, or first few weeks, they should be monitoring more frequently to understand the effect of all the types of meals which are being taken, effect of it, exercise which child is doing. So we have to do it for around say 15 days to 1 month to understand all types of meals, the effect of their effect on the sugar, all types of activities which child is doing. So accordingly we can adjust our insulin doses and then maintain those over next few months. Okay, so this type of data basically which is generated can again be used by analyzing it, and then advising what adjustment ought to be done. So they would be writing sugars here, say this is a pre-breakfast sugar on daily basis, we will get that trend. Similarly, post-breakfast sugar over few days, we will get that trend. So otherwise, right now what we are doing is we are manually seeing this chart, say for last 10 days, 2 weeks, 3 months, and then seeing whether they are appropriately giving the doses or not, adjusting the doses accordingly properly or not, in which they are actually, most of the time they are not able to adjust all the doses which are required and adjust it properly. So there is a role of some guide or some system which can guide them, or some technological advance which can guide them how much dose adjustment has to be done depending on that particular sugar. And obviously, if someone can test their sugar also without a prick, would be a great thing. So that again is a continuous glucose monitoring devices are there. They will round the clock show the blood sugar level status at that particular time. So this is how we practically manage them. This is sort of chart they would maintain. And then particularly suppose this sugar is very high, the bedtime sugar is 456. So they have to be alarmed and they have to understand that what adjustment insulin has to be done here. So they have already taken pre-dinner injection of 6 units. Pre-dinner sugar was 94, which was perfect. But suddenly this sugar comes out to 456 here. So you can understand that either this child, because previous day this 6 unit was sufficient, because sugar after that was fine. So here this child has taken something extra in the dinner, maybe some sweets or some extra puri sabzi or whatever. So the sugar has increased this much. So we have to correct it. So we have to give a correction bolus, we call it. It's not meal bolus, it will be a correction bolus, that whenever we detect high sugar, we should correct it with extra bolus, the short-acting insulin. So again, this is another decision which they have to make. And if they don't make it correct, you can understand this high sugar will remain high throughout the night and will damage the body's organs. So I just have to tell you that whenever sugar is high, it damages the body organs, particularly those with high blood flow, like kidneys, like eyes, brain, heart. So all these organs, and then peripheral nerves. So these are the main organs which are affected by high sugar. And even if it is high for, high means more than 180 or 200. So that is the danger level. So more than that will cause damage to the body parts. And this damage will go on accumulating over the days and weeks and months. And for after few hours, after few years, we would find that kidney has failed, or retinopathy has occurred, or vision has gone, and then blood pressure has increased, there are heart problems occurring, then हाथ पैर सुन हो रहे हैं, peripheral neuropathy we call it. So over the years, this happens obviously over the years, it doesn't happen in weeks or months. But when we have high sugars occurring for few hours also in a day, and that few hours, actually again the cutoff is around 4 to 5 hours. If it is more than that, sugar remains high, then it is almost sure that some organs are going to be damaged in next 5 to 10 years. So that is why we have to do all this stressful regimen to avoid those complications in the later life. And also when particular time the sugars are low or high, at that time also body doesn't function properly. So particularly in the school, if sugar is either low or high, child will not able to efficiently do his work or understand what is being taught or do physical activity or sports properly if sugar is either low or high. So it is important to maintain sugar in normal range as far as possible to function properly or body to function properly on day-to-day basis, and also to avoid those long-term complications down the lane. So hypoglycemia symptoms, I think most of you know: headache, sweatiness, shakiness, confusion, dizziness, feeling irritable, angry, hungry, and all those. So I think all of you know those symptoms. And what is the treatment? Glucose has to be taken. I won't go to more details of that. So these children very commonly have these symptoms almost every week or few times in a week. If they either take less meal or they either by default, by mistake, inject more insulin, so sugar will get low, or they do extra exercise, aggressive exercise without taking much snacks in between, so they again will get low. Similarly, high sugar will have similar symptoms of increased thirst, then increased urination, then problem with the vision, blurred vision can occur. Headache can be symptoms of high sugar as well, dry mouth, thirstiness, and weakness, because it's high sugar in the blood but low sugar in the body organs. So tiredness is there, body doesn't function properly. So all this is important to be known. So what is the treatment for hyperglycemia? Hyperglycemia basically we define in these children as 200 milligram or more of blood sugar. It has to be immediately corrected with. So there are basic rules. Extra dose of insulin has to be provided for 1 unit for each 50 milligram of extra sugar, more than 200. So if it is 250, 1 unit of bolus injection has to be provided immediately. If it is 300, so 2 units. This is general rule for an average child. But if it is smaller child or a bigger or older child nearing adulthood, so dose would be different. So that has to be taught to them. And again, there is a role of some advisor again. If it is a digital advisor, some app is there into which they put in their sugar value and that will guide them how much dose. So that would be good. So for every low or high sugar, again, they have to make some decision. They have to correct it immediately. For low sugar, they have to take Glucon-D or maybe sugar or something which is available right now, but Glucon-D is the best. And then high sugar, they have to give extra insulin. Then they have to find what was the reason for that high or low sugar, and next day they have to avoid it. And if they don't find any reason for any high or low sugar, then obviously they have to adjust the insulin dose, the previous insulin dose, as previously discussed. So diet, again, diet, as told earlier, has to be counted basically by some methods. There are carb counting apps also available now, which can help count the carb of a particular food, but whatever are available are more of Western diet. So we need to have local diet carb counting apps, which we need to develop. So carbohydrate counting is important actually. I think we just skip it for the sake of time here. Exercise, again, some adjustments have to be made during the exercise. We have to see how much is the sugar before exercise. Say maybe in middle of a aggressive exercise, we should check glucose again, and at end of exercise, only maybe for 2-3 days for a particular exercise, and then we know how much sugar effect is there for that from that particular activity or exercise. We can accordingly adjust. We can take some carb or some snack in between the exercise if required. So we have to maintain that normal range of say 70 to 180 is the normal range, and this is the range where we should do exercise, not Even if sugar is high, we should not do the exercise. Even if sugar is low, we should avoid exercising, and we should bring it normal by taking some snack or something. So insulin dose could be adjusted obviously for that. Now coming to the topic which is relevant to you maybe. So, but I think the previous background was important to understand the perspective, and then for the technologists or for the techies, people like you, to understand the perspective or the medical background. So I think that was important. And now I think it's more of your expertise which I'll be discussing. So I think we have to be thankful to the people who actually discovered insulin in 1922. And these 4 researchers from Canada got the Nobel Prize for that. And you could understand that this insulin was life-saving. Before that, these children or adults with type 1 diabetes were dying short of any treatment available. But unfortunately, since then, no other treatment has come up. So whatever has come up is the change in the technology or the convenience for these patients to get insulin. So insulin is the same, which was discovered almost 100 years back. But the method of giving insulin, the technology has changed. So maybe some of you would remember, those who are senior, that these glass syringes and these needles were boiled before giving injection. It was long back. So now insulin pens are available, insulin syringes are available. To avoid the pain and multiple pricks, some sort of gadgets are available. We just apply it and we can inject insulin into this rather than directly into the skin. So then for measuring glucose, earlier there were no blood glucose meters. This is the urine glucose meter. In the urine it was dipped to see the glucose level. Now we have continuous glucose monitoring devices. Some sort of sensors are put in under the skin, and it will just show the glucose level on the screen, with also some other information like predicting how much sugar is increasing or decreasing, or it is stable. So, and it gives trend for the last few hours as well. So these CGM devices are available. So these are the insulin pumps basically, which I showed earlier also. There are different designs available, different brands available. So pump, basically I'll be discussing more on this. The continuous glucose monitor, there are different types available. So basically what is CGM device? So it basically has a sensor which is part of the CGM or continuous glucose monitor device, which goes inside the skin. So there is a sensor or filament sort of thing which is injected into the skin, and then there is a transmitter which transmits the information from it to a device or monitor, so wireless monitor. So these are the parts of a CGM device. So these parts have to be there for it to function properly. So this is basic CGM device and the technology behind it. So we have different types available. Only problem is they are costly and out of reach for many of our patients, majority of our patients, if I would say, and they are not very readily available in India. They are available in the bigger cities at obviously higher cost. So there are thin flexible sensor which goes into the subcutaneous tissue. You can understand that this sensor does not detect the blood sugar. It detects the blood sugar and it detects the sugar in the tissue under the skin. It is not actually the blood sugar, but it is nearing the blood sugar. It is near to that. So actually blood sugar may be different than, slightly different than what these monitors are detecting. So that is a problem with these. Even if they are available, they are costly, but they are not very accurate when we compare it to glucometer or the blood sugar testing. But still they are very good to show the trends. As long as the sugars are within normal range on these monitors, we can go on managing the insulin doses accordingly without checking from these needle prick glucometers. So this is the interstitial fluid basically. This is the blood vessel and this is the interstitial fluid where the glucose is being checked by these. So it's a small filament which goes under the skin. The sensor filament is very fine, not painful at all, no issues with it at all. So there are different types available. I think I'll just, but all of them will have a sensor, a transmitter, and a monitor device. So all of them will have this. So some are costly, some are slightly cheaper. This is slightly cheaper and easily available in India. This type of CGM are basically compatible with the pump. So this CGM actually is showing the sugar on the pump. This is insulin pump, and they work hand in hand basically. So accordingly, we just put the sugar is already there. We just put the carb count, and the pump will calculate the insulin dose. So that is advanced in the technology, which I'll be discussing further. So these are the types of CGM devices. So these devices can be connected to our phones through specific apps, and they will show us a lot of graphs and information and data for us to interpret and understand, and for patients to basically decide the dosing and how much glucose insulin doses are to be adjusted and which doses are to be adjusted in the day. There is a new implantable glucose sensor also coming up. It has been approved last year only in Germany. And this is implantable. Basically, it is implanted under the skin like this, and it will show on the phone, it will show all the information. It lasts long basically. The other sensors, as you can understand, they last from anywhere from 7 days to 14 days, and every 7 days to 14 days, those have to be, the sensor part has to be changed. The transmitter and the monitor will remain same. Only the sensor part is disposable and has to be thrown away, and new sensor has to be inserted every few days, depending on type of the CGM. Some will require to be changed every 7 days, and some may be every 14 days. So there is a cost involved, obviously. So with this continuous glucose monitoring, now we have this range sort of which we can monitor, that how many hours a particular patient is remaining in this range. So this is, we call it as time in range. So when we are continuously monitoring the glucose with these CGMs, so what is the important parameter we are measuring? That is time in range. So how many hours or minutes in a day a particular patient has a normal or required target of the glucose, and how many hours or minutes he is below the target, how many hours or minutes in the day he is above the target. So actually the target is the time in range, or between 70 to 180 should be at least 16 hours in a day is the target. Patient should be having time in range of at least 16 hours, or maybe 2/3 of the hours in the 24 hours. We can say it like that. So, and low should be very less. It should be less than 5%, ideally 5% of the time, maybe less than 15 minutes or so. And hyperglycemia again around 15 to 20% child can be in higher range, to avoid those long-term complications. So smarter way of connecting with the doctor, these basically CGM devices or these insulin pump devices can be actually then connected to the software, providing data. This data is analyzed very nicely with these softwares, providing us different graphs, pie diagrams, giving us percentage of time in ranges and everything. So these can be used and analyzed by the doctors and then advised accordingly. And if we want to remove doctor from this, so this technology can work as a doctor basically, because patients cannot come to doctors every day or every few days. So in between the visits, say so they usually visit us every 3 months or so. In between the visits, this sort of technology can help them taking decisions, adjusting doses of insulin, etc. So there are a lot of websites and digital platforms available, all basically catering the Western population and patients on insulin pumps. However, in Indian setup, very few patients are on insulin pumps. So what we are managing is with the insulin boluses, with the insulin pens, 4 to 5 times in a day, depending on the parents and the families, how keen and how sincere and how motivated they are. They are monitoring their sugar with finger pricks by glucometers 4 to 5 times in a day, again depending on their motivation and all. So I think we need to develop some apps or some digital platforms or some sort of solutions in terms of gamification, artificial intelligence, which can guide these patients on daily basis to make these decisions and keeping them motivated. So these are again, I think, different types of glucose sensor data which are available for 20. These are daily data available overnight, breakfast, lunch, dinner times. So how much was the insulin being given by the pump as per the sugar values on the sensor. So this is another type of available CGM. These are the all digital ways of looking at it. So I think insulin pump, if I slightly explain it a bit more, this is a typical prototype of insulin pump. This is an insulin reservoir which is fixed here, and there is a rotary pump here which will push, it runs on the battery and push this reservoir slowly to provide insulin, inject insulin into this tubing into the body. This is called infusion set. So then this is the reservoir which fits in there. We load insulin into it for 3 days. So this is fixed to the reservoir, and then it is finally fit into the pump, and this battery operated plunger will push the insulin dose as per the rate we set in for every minute, for every hour. We can set that rate. So when we have to inject the bolus means before every meal we have to inject some dose, so we can press this button and give the desired amount of bolus. Actually this pump can calculate itself also. We call it bolus wizard. So it automatically calculates if we provide the carb count and the sugar at that particular time, the pump will calculate how much bolus dose is to be given. So this is important and easy to use for the patients. So what is sensor augmented pump therapy? I think name can suggest it that when we have glucose sensor attached and insulin pump attached, so sensor and pump, they are communicating with each other, and as per the sugar level, pump is providing the insulin. So this is the technical advance here. The CGM is there, sensor augmented pump is there, and this is what combination is called sensor augmented pump. And this is the standard of care right now for these patients, but they come at very high cost. So only say, I would say, out of 1500 patients we have in our hospital, only 25 to 30 patients are using insulin pump, and most of them are not using CGM because CGM comes out very costly. It costs around 15,000 to 20,000 per month to use the continuous glucose monitor on daily basis. So insulin pump is still, it's a one-time cost, and then it's just insulin which has to be put in, and those reservoirs and tubings have to be bought. And for pump, it's only to running the pump, it's only another 4,000 cost. So 4,000 plus 5,000 of insulin and sugar testing, it comes to be around 8 to 9,000 per month cost for a patient to get treated by insulin pump. But if we add CGM to it, it will add another 20,000. So around 30,000 of cost. So only few business people, those patients who are being reimbursed by the government employees, the parents of those children, they are using insulin pump in our setup. So the cost is the factor. Again, if we can develop these technology locally would be great and cost effective and obviously cheaper for our patient. So this is what we need and it's need of the hour. So again, I think these technologies explain more. Then another advance in the technology is low glucose suspend system. What is it? So the second leap in insulin pump was this another added function was there, which is called low glucose suspend system. What it does is whenever glucose comes down, say less than 60, we can set that point. The insulin will stop. It will shut giving the insulin. So it is basically auto-cut sort of insulin whenever glucose goes down. You can understand this will only work when CGM is applied. The pump is having that information of continuous glucose levels in the blood. So whenever glucose goes down, the pump will shut down the supply of insulin. So this is a safety feature that on a pump and on CGM, patient will not go into hypoglycemia. It's a very important safety feature, particularly in children, because if they go into hypoglycemia, they can develop seizure, fit, altered sensorium, coma. So that will require hospital admission. It will take 2-3 days to recover, and it is a lot of expenses, obviously, and a lot of problem, and it can be sometimes even detrimental to the life. So low glucose is very serious and emergent issue in these patients, and if some technology can help avoiding it, so that would be great. So there is suspension option is there with. Then there is another advance is predictive low glucose suspend. So earlier when the glucose actually got low, the insulin was stopped by the pump. Now the pump will predict, and then even before it gets low, it will predict it and stop giving insulin. So this is predictive low glucose suspend function, which is there in the insulin pumps. So it stops insulin long before actually the sugar gets down or is going to get down. Then there are hybrid closed loop systems. So what are these closed loop systems? These basically will also increase the dose of insulin when sugar is going up. So they take care of both ends of the sugar. Even when sugar is going up, they will increase the dose. When sugar is going down, they will decrease the dose. So this is called closing the loop. What is the loop here? I'll just explain. Loop here basically is glucose in the blood, then it is sensed by something, then insulin is given accordingly, and the sugar level normalizes. This is the loop which we need to close with the use of technology. I'll be explaining it a bit more later on. So this is the latest insulin pump, the hybrid closed loop they call it. So this senses the glucose, and it will actually adjust the basal dose which is being given, which we have already set, but it will adjust automatically depending on what is blood sugar level. But still it is not able to give extra insulin for the meal. For the meal, patient still has to press the amount of carbohydrate has to be entered, and then only it will calculate the dose and accordingly inject the insulin dose. So this is called so basically it without meals it can manage on its own. Patient doesn't need to do anything at all. But if patient is not taking any meals, the basic background insulin this pump can manage. But for the meals, we have to enter the value of carb count in that particular meal, and then it will inject. So this pump is actually available in India, quite costly. This is the approximate cost of these pumps. The latest pumps cost around 5.6 lakhs, which has a predictive low glucose suspend function. The advanced one is still not available in India. It's called 670G, which is closed loop one, the hybrid closed loop. So this is how it is applied basically. This is the glucose sensor, and this is the transmitter. It is transmitting glucose value here. It is in millimole, so it's looking 5.1. So it is around 90 in milligram per deciliter. This is the cannula, and this is the insulin being injected. So these are different types and shapes of sizes of insulin pumps available abroad. In India, the Medtronic, then there are some variations of this model now available. So this particular pump is quite popular with the young generation there in the West. This doesn't have any tube. This is basically patch pump. This pump is fixed on the arm, and it has insulin in it for around 3 to 4 days, and then whole of this pump is discarded. This is disposable sort of pump, and it has a handheld device with which we manage everything, or this device gives instructions to this pump. So can children use the pump? This is very important and common question with the layman. So we have infants using insulin pump. In fact, insulin pump is more useful for infants or smaller children because they are not taking 3 meals in a day. They are taking meals or milk every 3 hours or so. So we cannot inject insulin every 3 hours with the insulin syringes or pens. So pump is very useful for them. In fact, in the West, for less than 5 years, it is pump is the treatment of choice, and they will always advise pump to all children less than 5 years because they are taking frequent smaller meals. So they will require frequent smaller insulin doses, which pump can easily give without any needle pricks. So this is how it is fit in one of our patients. So what are we talked, basically we have to teach these patients and parents. So we have made such education booklets for them to refer at home. We have covered whatever we have discussed today. It is in more details in the local language is given, this booklet is given to them. Machine learning and serious gaming based digital platforms. This slide has been borrowed from Dr. Khosla. So you can see that how it works. This is a patient basically with the inputs of blood glucose, insulin intake, carb count. It is entered into some system which could be easily smartphone nowadays, and it is connected to the cloud and the internet, and it can provide back some recommendations regarding diet, exercise, insulin dosing, etc. Then for motivation and gaming part, we can have these leaderboards, badges for their involvement, active involvement, and more interest in their treatment. And then this data can again be analyzed by the doctors, and we can provide them feedback, risk analysis, and basically a control over this technology by someone who has the medical knowledge. So this is how the serious gaming and machine learning can help in these patients. And it's not just our imagination. People have actually used it, and there are many such studies available for children and adolescents. Although these were not very extensive or holistic apps or technologies, these are just smaller apps where they enter the glucose values, the doses, and some sort of analysis can be done. Some had some gaming component as well, but they did not improve the outcomes of these children very much, and the acceptance was very less actually. We do attend many international meetings, conferences, and what is experience of these clinicians abroad is that the uptake or acceptance of these digital platforms is very less in patients and parents and children. Somehow they use it for a few days and then they lose their interest. I think that is where the important role of gaming is there, and for their interest which is to be maintained through some gaming strategies. So this is another clinical decision support system available on the web. It is similar, CGM or pump or pen. There are digital pens also available now. They can be attached to the software or through Bluetooth or something, and they will automatically upload the insulin doses which are given over last month or last few days, or what doses, how many times in a day. So all that information can be fed into the software, and then clinical decision support can be done by the algorithm, and accordingly the physician can analyze those and give recommendation to the patient. So such type of technologies which what we are thinking of or expecting. So another similar web-based platform which provides decision to the patients sitting at home and doctor sitting in his office. So again, all the information is provided by the patient to this advisor. They call it digital advisor. So this digital program is advising rather than doctor advising. So and advising on daily basis and number of times in a day. So doctor would overall supervise this. Obviously, it is difficult to replace the doctor. So technology has to be monitored by a medical expert, obviously, and which can be done say every 3 months or so. But on daily basis, this could be very useful. So another web platform called Tidepool. It's a free web platform provided by support from Juvenile Diabetes Research Foundation in US, and they provide this platform to upload information or data from all types of glucometers. So whatever sugars are there in the memory of the glucometer, it can be uploaded and it generates a lot of information. Similarly, for CGMs also, it will give us the percentage values which are in range, which are below range, which are above range. It will give lots of graphs and analysis, which is very useful for the doctors at least. And even patients can understand that. So these are all types of available glucometers even in India, whose data can be uploaded on this software. So this is the technology, how has it advanced over time. So I have discussed with you low glucose suspend pumps, then predictive low glucose suspend pumps, then hybrid closed loop, and then we are actually looking at the artificial pancreas device system, the artificial system which actually works like our pancreas, that it decreases the insulin secretion when sugar is low and it increases the insulin secretion when sugar is high, and has this very fine control and keeps the blood sugars in the range of say 80 to 140 or 180. So this would be the closed loop system which we are looking at, and this is how the technological part of these artificial pancreas will look like. So we have to sense, as I told in the initial few slides, that in the pancreatic beta cell there is a glucose sensor, and after that some chain reaction starts, and there is potassium channel which is blocked, calcium influx occurs, and then insulin secretion occurs. So similarly, there has to be a continuous glucose monitoring sensor. Then there has to be a receiver for it, or transmitter for this. Then this receiver will convey this glucose information around the clock, every second, every few seconds or so, and to this device. And this device will convey to the insulin delivering device. This device is basically nothing but a control algorithm which has to be generated by the technical experts like you, and this is the insulin pump. These are the four parts of this closed loop, which we can say, or we also call it artificial pancreas. So these are the components, and we have to develop these. In fact, many engineers abroad or technical experts whose kids and kins are having type 1 diabetes, they are doing it themselves. They call it DIY devices, or do-it-yourself devices. So they are using it, using Apple iPhones or using even laptops, generating these algorithms, and they have developed their own technical things, even if they are not approved by the doctors or by the US FDA, which regulates the technology in the medical field. So, but they are using of their own. So these are called DIY devices, do-it-yourself devices, and they are actually doing it. So although these systems could be crude, they are not for commercial use, but individually anyone can treat himself or herself as he or she wishes. So closed loop systems are actually, I think I have already discussed that. This is I think I have explained it with the previous diagram. So this one of the earliest closed loop system was approved last year in December. Not even a year has passed. Called tandem closed loop artificial pancreas. It works like that, and it adjusts our food boluses. So we don't have to enter anything. Everything has to be done by the technology. We just have to apply the technology. It has to be functional technology. We should be tech savvy, but we don't need to enter sugar values because that sensor will already automatically provide. We don't need to enter carb counts also, because sugar level, whatever carbs we eat, the sugar will accordingly, level will be conveyed by the glucose sensor to the pump and the algorithm, and it will increase or decrease the dose of insulin accordingly. So this was actually a do-it-yourself device to begin with, and it got commercialized and approved. So people are using obviously phone apps for using. This is the sensor which is being used from Dexcom company. This is the pump company called Tandem. So I think I've already discussed this. This is another Diaby loop which is approved for use in Europe, not in US though. Again, it's some Chinese, in fact I think Korean company which has made this along with a company from Europe. So lastly, I would talk about artificial bionic pancreas. What is bionic pancreas? So basically it is even more closer to what our pancreas does. Pancreas basically has another set of cells. The beta cells make insulin, but there are delta cells which make glucagon also. So glucagon, what is the role of glucagon? It increases blood sugar, and insulin decreases blood sugar. So it's not only decreasing the dose of insulin that sugar will increase immediately. It will still take some time, because insulin already is there in the blood. Even if we stop from the pump, the glucose will not rise immediately. To increase the glucose immediately, we need another hormone called glucagon. So if a pump has both the hormones in it, insulin as well as glucagon, then it actually is a true artificial pancreas. And it is called as bionic pancreas. Pancreas like our biological system in our body. So this is what is the true artificial pancreas or artificial bionic pancreas, which will have both the hormones. The hormone which increases the sugar and hormone which decreases the sugar. So keep that balance. We need both the hormones, and they are connected with the tubing, and similarly with the subcutaneous delivery it is done. Obviously glucose sensor has to be there, and there has to be a control system which has to work. So people are actually working on this, and it has reached in quite an advanced stage now. In fact, the main person who is leading this project in Boston is this father of a child with diabetes, and he's an engineer. And this is how it looks like. They call it islet. Islet is basically another name for, we can say, it's pancreas. So it's called islet is a company. It will have both insulin tubing as well as the glucagon, and then maybe into a single one and being injected into the subcutaneous tissue to a type 1 diabetes patient. Thank you. I think I have taken a long time.
Thank you, Dr. Rakesh, for providing valuable information to the participants. Any question from Dr. Rakesh?
Yes, sir. I would like to ask a question. First of all, congratulations, Dr. Rakesh, for so much information and for all the work you're doing. Also, congratulations to Dr. Khosla for all the contribution that he is doing. Doctor, my question is regarding a person who, people who do not have this sugar count that comes in the reports after the doctors give, but they still have all the excessive sweating, a lot of thirst, being very hungry, frequent urination, but still having low fatigue and feeling inactive. So they are having all the symptoms, but the sugar count.
But they don't have diabetes.
Yes,
That's
they don't
what you
have
are saying?
diabetes. Yes.
Okay. So that is understandable. All these symptoms you can understand: feeling low, feeling lethargy, feeling tired. In fact, all of us have experienced these symptoms even if we don't have any illness. So these are symptoms not only of diabetes, these can be symptoms for many other illnesses, or these symptoms can be transiently there to many people without any reason. So these symptoms are not specific to diabetes. Again, I would say that. There are a number of reasons for frequent urination. There are a number of other reasons. So I can't discuss those medical details, obviously. But if these symptoms are there and sugars are normal, we have to be checking it repeatedly. Sometimes 1 or 2 times we may not get the high sugar. And if sugar is sufficiently ruled out, we should be looking for other reasons. There could be many other reasons causing these symptoms. I hope that answers your question.
Yes, Doctor. Thank you.
Dr. Rakesh Kumar, this is Dr. Biswas. I have a question, not question, I need to know about when a person is having high sugar, 400 plus. So when doctor has given double dose, tablets, in the morning and evening, and so that and drastically within a week, the sugar gone down to 140, 160 like that. So in that condition, what will be the impact?
So it should not have much impact. if it is going low in over few days. But if it is going from say 400 to say 100 within few minutes or within few hours, then person can feel like having low sugar even if he has 100 sugar, because body is adjusted to higher sugar levels. And if we rapidly decrease it with some injection insulin to within normal range, so person may feel low sugar because he is already adjusted to the higher sugar level. So this is the only thing which can happen. Otherwise, it has to be brought down, and that is the only reason that dose of the medicine was increased. And if it occurs over days, it will not harm at all. Rather, it will benefit. What you are talking is obviously about the type 2 diabetes. The tablets are given only in type 2 diabetes. What we have discussed today is type 1. It is totally different ball game. Okay.
Thank you. Thank you.
Dr. Rakesh, there's a question in the chat box.
Okay, I'll just...
Does diabetes go away if food intake is regulated as soon as it is detected for both type 1 and type 2?
So for type 2, yes. For type 2, I would say yes. If food is regulated, we start taking exercises, things can be reversed. But that is true only for type 2, not for type 1. Type 1, once it starts, it will never go away. We still have to see a patient in the world who has grown out of type 1 diabetes. Type 1 diabetes is a permanent condition. Yes, there is a small phase, we call it as honeymoon phase, which is a normal natural course of type 1 diabetes. Sometimes what happens when patient comes to us with these symptoms, we start insulin, and when sugars improve, even those beta cells, they feel more healthier, they get more glucose and energy, they start producing whatever reserve insulin they have. They start overworking and they give some insulin to the body, and extra insulin is not much required. So for few months, patient can do all right without any extra insulin provided from injections. So that phase we call it as honeymoon phase, but even that phase does not last for more than few months. And when it is lost, that honeymoon is over, it is a permanent diabetes, basically permanent type 1 diabetes. There is no cure of type 1 diabetes, and it never goes away. Whatever you do, it will not go away. There are a lot of things people have talked about, like stem cell transplant, like there are many quacks around कि हम ये कर देते हैं, वो दे देते हैं, ये हो जाता है, वैसा हो जाता है. Type 1 diabetes, nothing helps. What only helps is insulin, giving insulin. So many of our parents particularly, they try different such babas and maybe other people and other forms of therapy. So they are okay to do it because it is their child and they want to do whatever they want to do for their children. But what we advise them is that don't stop insulin. Whatever forms of therapy you want to try, you can try, obviously at your own risk, but don't stop insulin. And if that particular therapy will work, obviously the child will get low sugars if you are giving insulin injections, and then you can stop the insulin injections slowly. But this usually doesn't happen, obviously. Whatever happens is that part of honeymoon phase. And some people actually, the babas and those quacks, they make use of that honeymoon phase. वो दिखा के उनको एक बार को बोल देते हैं कि हमने आपकी डायबिटीज ठीक कर दी, पर वो हनीमून फेज होता है जिसमें इंसुलिन का डोज थोड़ा कम हो जाता है और पेरेंट्स को भी लगने लगता है कि हमारे बच्चे को शुगर थी ही नहीं और हमें ऐसे ही इंसुलिन दे रहे थे. तो अचानक से फिर क्या होता है, जब वो हनीमून फेज खत्म हो जाता है, अचानक से वहीं के वहीं वापस पहुंच जाते हैं जहां शुरू में था. अचानक से बच्चा बीमार होने लगता है, बिल्कुल थक जाता है, बेड से उठ नहीं पाता, और वो जो एक्यूट कॉम्प्लिकेशन शुरू में हुई होती है वो वापस शुरू हो जाती है. फिर वो वापस हमारे पास आते हैं काफी सीरियस हालत में, फिर वापस से इंसुलिन स्टार्ट करना पड़ता है. तो सम पेशेंट्स एक्चुअली एक्सपीरियंस दैट थिंग. So for type 1 diabetes, no cure. It doesn't go away. We have to provide insulin. I mean, we have to think scientifically also. It is the insulin which is not being produced in the body because that particular organ has stopped working. Yeah.
Thank you so much, sir.
Okay.
Thank you, sir.
Another question, any gamification applications are available for managing type 1 diabetes?
Yeah, I just reviewed this a few months back, and yes, there are some gamification applications available, but they are not, I would say, worth. They are just sort of creating more. What should I say? They are sort of companion to these adolescents, but they do not actually improve the glucose control. They do not actually improve their involvement and motivation, and they usually stop using it after a few months or so. So another issue is, yes, they are there in the West, but these, I think, have to be locally customized, because our diet is totally different, psyche of our patients and parents is totally different, their tech savviness, if we call, is totally different, literacy level is different. So we have to have our own locally made gamification apps. Yeah.
Yeah, I just want to add on top of it. PGI Chandigarh and NIT Jalandhar. So we are collaborating and we are trying to create this platform. So this is the initiative we are taking. We are in the starting phase. So we are trying to create this platform, as Dr. Rakesh said, for our kids, to meet our local requirements, which should not be. Obviously, we cannot copy things as such from what is happening abroad. So we'll have to make those apps or these platforms which are suited to our conditions, which are suited to our eating habits, our menus, whatever we eat, our lifestyles, and so on. Thank you. Any other question? All right. Okay, let's thank Dr. Rakesh. From all the participants, I express my gratitude to Dr. Rakesh for sparing his valuable time, especially doctors' times. They are so important these days. Otherwise, also because of the pandemic situation. Thank you, Dr. Rakesh, for sparing your valuable time and sharing, educating all of us. Because, as I said in the beginning, many of us are not aware of what type 1 diabetes is. Largely, they're only, when say type diabetes, it means type 2 diabetes. Managing type 1 diabetes, it's so difficult because we can make out eight breaks per day, and that too for kids, and maintaining a very stringent regimen. So obviously that is very, very stressful. Again, we appreciate the contribution of Dr. Rakesh for serving the society and managing the patients very efficiently. We extend our best wishes to Dr. Rakesh, and thanks to all the participants for patience hearing.
Thank you very much, sir, and thank you the audience for active participation. If I may add that many of our patients are very poor. I am just sort of publicizing the society our patients' parents have made. It is called Association for Children with Type 1 Diabetes, Chandigarh. It's a registered society in Chandigarh. And I don't know if you are seeing my screen. It's a short form of ACT1D.com. I mean, they have a website, ACT1D.com. So maybe you can just log in and go through. Share it with your nears and dears. Basically, it is society raised to help the poor patients who cannot afford treatment of type 1 diabetes. You can understand it costs 4,000 to 5,000 per month, and many of our poor patients, majority in our center are actually poor patients coming to government setup. So if you can just help these patients, if some of you can help and contribute in whatever form. Obviously, most of you should be contributing in developing some usable, cheaper technology for them. Yeah, that's all I would say.
Yeah, thank you, Dr. Rakesh. Thank you so much.
Thank you, sir. Thank you.
There's another message for the participants. The next session, it was scheduled for 12 noon, to be engaged by Dr. Abhishek. I just got a message from him. There's a power outage. There's some technical issue at his home. So that may, which means this session is required to be postponed, right? So we'll have to reschedule this session. So maybe today evening or tomorrow afternoon, because tomorrow afternoon we have a valedictory function. Probably it can be clubbed with that. So what's your opinion? So can we have this session tomorrow afternoon?
Yeah, that will be fine.
Yes, sir. I think that will be better, sir.
All right, all right.
We can club it with the validity function tomorrow, sir.
All right, thank you so much.
So today evening also it will be okay if it's possible for the speaker.
So I have to give him one, two, three options. Maybe today evening. I think tomorrow evening should be fine.
Yes, sir. You can update in the WhatsApp group. We are okay with everything.
All right, all right. Thank you so much. Thanks for your support.
Yes, yes.
Okay, sir.
All right. So we have now next session is scheduled at 3 p.m. today.
Okay, sir. Okay.
All right. Thank you.
Thank you,
Enjoy your
sir.
lunch. Okay. Bye bye.
Thank you.
Hello.
A very, very good afternoon to everyone. Am I audible?
Good afternoon, sir. You are audible, sir.
Please let me know. Am I audible?
Yes, sir. Good afternoon. You are audible, sir.
Am I audible?
Yes, sir. Yes, sir. Please go ahead.
All right. Thank you so much. Thank you. So we are about to start with the next session. So the expert for this session is Dr. Girish Pujar. He's a scientist with ISRO and is heading Rural Development and Watershed Monitoring Division in ISRO Remote Sensing Area, National Remote Sensing Center, ISRO, Hyderabad. And we are lucky to have Dr. Pujar with us for delivering his talk. In fact, we are working with ISRO on a project which has been conceptualized by him. He has been associated with the National Remote Sensing Center running a lot of activities. And one of the activities with which he has been associated is Manrega. Around Manrega, he has planned a gamified solution so that the contribution of the stakeholders that can be taken to the next level for the benefit of the rural community. So I'll invite and I extend heartiest welcome to Dr. Pujar and request him to kindly start his session.
Good afternoon, everybody. Thanks for the interest that you all have taken to join my discussion. Thanks to Khosla sir for a very warm welcome and a warm introduction. I am associated with the Rural Development and Watershed Monitoring Division. This is formulated in 2014. It was a new decision to support all the rural development activities that are going on across India and how to use remote sensing to monitor those activities. That was a question. So we are around 5-6 people here with enough experience in handling remote sensing data. This session is really very special to me because I'm basically a thematic guy. I hold PhD in forestry, and this idea of coming to a gaming interface, etc., have their own history for me. So I am trying to put my perspectives into this discussion and try to see like how whatever the knowledge we have can go into a meaningful game which will help this process. So now I am sharing my presentation to all of you. So any questions in between, you can please stop there because sometimes they may be totally concepts outside your domain. So my request is wherever you feel no, there is a clarity required, you please stop me there and we'll again catch back the process. So I have titled this discussion as Gamifying the Planning Process for Geo-Manrega. Few of you might have heard this term Geo-Manrega, and many more might have heard the term Manrega. MG stands for Mahatma Gandhi. NREGA stands for National Rural Employment Guarantee Act. See, it's not a scheme, it's an act. It's world's one of the distinguished labor act, which says that if the citizen asks for a job, government has to provide it. If not, he'll be paid compensation. So it's an act, which is actually a very powerful program to bring employment to people. So the need for a gamification and the perspectives of this flagship rural development in the overall geospatial context I have tried to discuss here. Essentially, Manrega has been considered as a very glorified ditch filling program. People would tell that people will dig the mud from here and put it here and you are paid the money. There was a sarcastic comment against that at one point of time. But later, a lot of things have happened, and we'll come to that point of discussion. So when you come to a rural development scenario, our division itself is named as Rural Development and Water Monitoring Division. See, we have one more strong program on monitoring integrated watershed management program, which is about looking at all the watersheds that are funded by Government of India. What is happening? In that context also, this rural employment generation assumes its significance because rural employment process is the one which actually leads to rural development. This rural employment generation is actually the core of this entire MG Narega process. Earlier it was called Rega, EGA. Well, we were at our bachelor level and I did my graduation from University of Agricultural Sciences, Dharwad. So when we studied our subjects, this EGA was a very pet subject around rural development. So it gradually got into different layers. Now it has become MG Narega. See, when you come to rural development term, the 5 terms I have written here. These are the few of some of the leading villages that around that list some 10 leading villages of India, 10 richest villages of India, etc. Ones I have listed here actually they connote distinct efforts of bringing rural development in a most indigenous way, because this domain of rural development somehow remains pretty on the periphery of whatever you call as a core scientific programs of an institution. Nevertheless, this actually runs the engine of the Indian economy. If villages perform properly, all stocks will be at a better place. Because food is very critical and most of the natural resources are actually taken care by villagers. By choice or by compulsion, there will be requirement. So, these 5 villages, they represent some of the best villages you can get to know about the development, etc. You can always search back these names and see. Surshet Tikopa you may not get, but it is one of the best agroforestry rehabilitated villages. My whole brush with gaming started with this SimCity some time back because the kind of graphics it delivered and the kind of imagination it captured, it was always hanging in my mind. But when we started doing this Manrega monitoring, I thought why not use it for rural development purpose, because villagers, they need some real proof, hard proof. Unless it's visible to them, unless it is quantifiable to them, they will not hear you. They are very practical people. So, this as a sim city, if you can construct a city virtually and do business over there, being a mayor, because you have to become mayor in sim city, and you have to invest in such a way that you actually run the economy better and better, and more investment will come. That's how you are predicting or scoring things now. So, with all this background, if you look at the rural employment generation scenario, because either a city or a village, there should be some job. There is no job, the society is gloomy or people will just migrate it. It means that habitation or whatever will become empty. But there are no jobs is why people will stay. So when it comes to villages, that's what I told. The first point says that the state has to provide employment to seekers within stipulated time. That is the beauty of this entire Narega Act. If you don't provide, then there will be compensation from government side, which you may get sometime cut from officers' salary itself. So it's a very serious business. And this entire rural employment generation process is the very strong case of mandated welfare measure. See, government actually is more of a welfare orientation. It's not a profit orientation. So among that, Narega is one of the top flagship welfare measures for unskilled. See, skill word is a very complex term. And we always consider people who are landless and they might not be doing agriculture. They have very least skills. So for them, employment has to be generated. Otherwise, they'll just move away and you have a huge burden on the cities. But of course, post-corona lockdown, we have seen enough reversals of this process. Then, while people were doing employment generations, you see, the repetition of works at repeatedly target locations led to displaced ideal, means people got bored. In Narega, only people are doing same work at the same location and money is given. So it became a very casualized process. So in that, the government thought that no, there must be some kind of fresh thought, fresh thinking into it. So they gradually started thinking that we should bring some more technology into it. That's why generation should be based on scientific principles of regeneration, but yet productive. See, when you go to a village and try to improve its forest, it will not earn you money. But if you manage the same forest in a different manner, it will earn some money. So it should be on a proper scientific principles. Then only you have generated the employment as well as brought back the sustainable development. Then, when you are going to give rural employment to people, you should consider for next 5 years what I am going to do in this village, so that I am going to generate employment. Whether I am going to dig the soil, or I am going to construct a house, or I am going to construct a check dam, or I am going to plant trees in coming 5 years, so that I have enough employment generation scope generated. Then, generally, when you target the people, the landless people, definitely they have lower motivation. Maybe they are from a lower strata of the society, or they may not be very economically, participative, because they may not have economic say. Then probably they may be low skilled often. So what happens? These things, when a weak transparency comes into picture, like a huge money program like Narega, a lot of money. You know, the current allocation for Narega is around 1.2 to 1.3 lakh crores, because that's a huge rural development investment. So with that, you don't have proper transparency, it is go to really weak accomplishment. You wanted to generate rural employment, but it never happened. So with all this background, ministry decided that we should bring space technology into this Narega program. And somebody has put the mic on. Can you please mute the mic? Please mute the mic. So with this all background, ministry decided they should bring geospatial technology onto Manrega, and they called it as GIS implementation of Manrega. Means Manrega will be implemented through a geographic information system, they say. So this Geo Manrega formulated like this: 2016, the MOU was signed between ISRO and Ministry of Rural Development, with a lot of luminaries associated with it. So when you call this MG Narega, Mahatma Gandhi National Rural Employment Guarantee Act, and its future planning, you have to plan a lot of works. So there are 260 works in this entire spectrum of activities, which may be sometimes repetitive, but for different groups, different people, different site, different season, etc. A lot of variation comes, so that becomes a 261, a larger number. The last one to add was the rooftop water harvesting. So whatever becomes an important activity in village, it gets added to a list called permissible work list. So that is the basic framework of that. So if you see the overall evolution of Narega, you see in Narega, ministry felt that you cannot just go on constructing toilets or school compounds. You had to, or just keep on digging the soil. You have to do something more. That means you had to bring in more scientific principles such as water conservation, watershed approach into natural resource management, which is called NRM. Then it will run the Narega in a stronger fashion. And when this thinking came, by that time, a larger phenomenon had happened in India. This Geo Manrega actually put all rural area workers on fire through this GIS system. We enabled a web-based GIS system, wherein people used on the field mobile instrument. They collected all the geotags of the locations and put it back. Today we are running at 3.7 crore of those assets of one category, and another 50 lakhs of phase 2 category. Phase 2 means you actually take 3 stages: before, during, after, and report it onto the database so that you know what is happening. So now we have built a huge super pool of geotags. I want to call it a super pool because probably across any other domain we don't have this size of geotags in government project. Then As I told, there was a very massive response of the functionaries who are involved on the ground. All the people got said, no, we have to use this app and report as much as possible. The ministry made awards for this process. They told who are uploading the best quality assets, etc., etc. Then this gradually enabled realizing the strength of GIS approach. GIS means you will involve digital maps. You have a geographic information system, which involves either satellite imaging or field maps and so many things churned through a database querying mechanism. Then gradually entered into a phase of planning of future works in a scientific manner. As I told, bring watershed principle into it. Then, on the parallel, we now have an abundance of open source datasets in terms of imagery, in terms of produced maps, etc. Plus geoprocessing too. Geoprocessing means you have two layers, two maps, you want to overlay it or cross it or intersect it and try to see what is happening. So 2 or n, any number of maps. And all that processing, that's now available as a more of open source type. Then people also learned how to handle so many concurrent users in a given time. Suppose you float a national level website like this, given moment you have 3,000, 4,000 people using the disk. So the concurrence, the strength of your hardware to use that, handle that concurrence is really important in such national programs. Then you have seamless web applications started coming. Means you develop in Android, it will open in desktop. Open in desktop, do it in a desktop, it can open in Android. The progressive web applications. So that made the development, rendition, handling more and more easy. And on the other side, like people like us, you've been understanding is if you do this, this will happen. Means if you do a farm pond, you will see a blue patch. If you do a plantation, after 3 years it will become green. Remote sensing based of whatever the work you have done and what impacts it has. And finally, we are now into a phase wherein a lot of very high resolution Indian remote sensing satellite data are coming up, which are of sub-meter resolution. Means you can see smaller and smaller assets or smaller and smaller works that are done on the ground. So why this is important is setting up a context of Narega for a gaming purpose with all this background puts you in a perspective like how we are going to introduce the concept of gaming into this. See, the same thing I explained on the flowchart here. You have super pool, then you have a lot of people studying in states who have a lot of expert knowledge on all these activities. Then we have ISRO, NRSC having a lot of spatial data sets. They all will come to the planning process because you have to plan better and better assets in the future. It may be assets, but finally it may be handling of the ecosystem itself. It's how you are handling landscape as is the question. This actually comes into the true core of Bhuvan Geo Manrega because this is one of the main process of planning. So when you say Bhuvan Geo Manrega, you have two verticals currently. One is a planning portal and there is analytics. Means you have such a huge super pool of geotags, it has to be analyzed properly. Then only it makes a meaning. For analysis, either you use existing commercial softwares or you use open source softwares like R. And for the planning purpose, you do planning, some standard plans, in some sample areas, tell people, look, the planning will be done like this. Here comes the role of whatever we are talking is gaming also. Plus, states are also doing some of the plans on their own. If they are doing it, then what is the quality of that plan? So this entire thing sets up the framework for monitoring the entire process by Department of Rural Development. DORD is Department of Rural Development. So this is how multi-institutional mechanisms handle multi-source datasets and bring out a mechanism of handling the welfare problem. So when you come to a map, because we have been talking about spatial database, etc., a map can be a base for the game beginning because a map has an ability to transcend the language. So when you say geographic information system, you have a lot of intuitive cognition going on when you see a map. You have direction in the map, you have map elements, you have adjacency of entities. Then you have contour here. Then you have shadows in the satellite image, which will convey a lot of information. And you have association of things with other things. See, if you see the maps here, you see there are many patches. See, this pink, darker pink is dense scrub, lighter is open scrub. Then this is the agriculture area. Then there is railway line, there is road, there are drainages. These are all the different entities that are overall aligned in a particular fashion. And on the right side, you have a high resolution image. There is a hillock, there is a shadow. It's in the context of plain area. And there is one more association of lot of crop along with the water flow. It means you are intuitively understanding many things without writing even a single sentence. Similarly, this is another map slightly zoomed out to show how forested area or green areas look like and how it is interspersing the agriculture area with its own drainage structure in the landscape. Similarly, when you come down to these illustrations, just to try to tell you how objects get manifested in a high resolution image, and you have to identify those objects to make meaning for that database. I don't say map, but essentially this also is the concept that will drive setting up of a gaming initiative, because most critically, people who haven't studied anything properly can also use map after basic orientation. You know the road, you know the pond, you know his house, he will definitely tell this is that, because he's orienting himself, like he's seeing the star and orienting, he's orienting himself onto the earth. Then once you are opening an image, automatically you are immersed into it, because you are on a 2D, you are slightly immersed. If you get into more and more immersive experience, you will definitely be part of the entire visualization. But without that also, you are actually locked into the entire entities that are available. So maps will bring that effect on you. And the open source GIS softwares, and I say ocean of remote sensing, a lot of data sets are available, are actually disruptive of conventional approaches. Like the conventional approaches where you handle projects like tables, or you try to look into it by a conventional mode of thinking, it's all becoming outdated because so much of data, so much of GIS systems. And the high resolution imaging will bring such a detail of understanding for villages, because villages till now they were mapped with very coarse resolution, which just made them in a small patch, that's all. Now as the detail is coming, we're able to appreciate further and further details in the village setup, and definitely you can map it in a more precise manner. So when you look into this entire process of mapping and how it gets into gaming, you see here, you start looking at a landscape by the inventory. Suppose you want to know all the farm ponds. Yes, you have done inventory. Then you get an image and map them. You draw all that location. The maps are available, you draw them. Then you take year 1 image, year 2 image, or season 1 image, season 2 image. You monitor what is happening to those water bodies. They are there, they are drying up, or they are expanding like that. Then you model out, you know, okay, these are the rules by which the water fills into the farm pond, or these farm ponds are coming. So you model using some mathematical only. If this landscape is of this nature, only these many farm ponds can fill it. That's modeling. Then once all this process has happened, then comes the I feel, I mean, I perceive here now, the post-modeling scenario is gamification. You have models developed. You have process models understood. You throw it into a game. Let the people come and try to do a mistake. By the virtue of model, you tell that only this much is possible. In a totally waterless area, if I want to plant some farm ponds, I have rules. I will give that rules. So it will gamify. It will say there are 12 farm ponds possible in this area. It will come up because you have model behind you. When you do all this, probably you will go into augmented reality. You have done something, you want to see it on the real earth surface. You go stand there, wear a Uzix, look at it, and you see a farm pond there. So that's how this entire business of geospatial logic will transcend into a higher reality, higher perception of reality. Then, as I told you, we are looking into a panorama situation where huge databases are being made available to these projects. But when you bring in a lot of data sets, you bring both opportunity and threats, or rather weaknesses, I should say. Because GeoMandrika is definitely a very large database, and that large database puts this entire need of gamification into perspective. You have so many records from the ground, whether those records are proper or not. If you want to create better records from the ground or better assets on the ground, how you have to go ahead. That's why the gaming becomes an important part here. But looking at a larger database, with a large database definitely will spawn a lot of thoughts. See, I have given a photo of a beehive. I'll come to that again. See, first of all, when you go for large area inventories, huge number of personnel, a lot of people are there to do the same inventory. So variation in capabilities happen. He may be skilled on SME skilled, non-skilled. So you will carry forward his error into the database. Then you have errors in collection and identity gaps and misrepresentation of the facts. And many times the government process will not allow you to facilitate the entire process in a meaningfully planned period. For example, storage. If your storage doesn't come by the time your data is created, where you will keep the data? You have a problem, you will keep it, share it somewhere. Then when you collect it back, you have errors. So these kind of very critical bottlenecks may exist when you create or when you are going to create large database. But at the same time, the opportunities look like at a grassroots level, you will develop a lot of comprehension. Then you have a multi-thematic orientation of works. As I told, there are 260 entities. There are so many entities you are seeing a huge taxonomy of entities. They all have to integrate and becomes one holistic solution. Then when you are doing large database handling, you gradually have to benchmark yourself against the market level technology leaders. If you don't do that, there are people who know ins and outs of handling such data, and you will cut a sorry figure, or you feel that you are not doing justice for handling such a large database. So your benchmarking becomes important. And finally, when you build large databases on something, because they are all having precision at certain level, it will become deterrence against corruption. Because he has to tell, at this point I have done this. If he has told, anybody can go and ask where it is done. So there is an app called Jan Manrega. Anybody can download it. Jan Manrega. It is actually a citizen verification app. Why I kept the image of honeybees? See, bees will bring honey, the data, with a total precision of rules embedded in them. Sometimes those rules are not applicable or they are not practiced by human beings when they are involved in larger inventory. So your honey will not be tasty, or your honey beehive may not be very regular. All those issues will come up. That's why there's a lot of sort associated with large database. Then with all this, when you come to a planning situation, first you have to understand what has been available in the situation and how you are going to plan. You see, this entire planning runs on a concept called ridge to valley planning. See, it is a ridge, this is a valley, flat valley. There are ridge treatments, there are drainage line treatments, and there are area treatments. Wherein in ridge, you have to slow down the water. Drainage line, you have to make it to stand so that it will start percolating into the soil. And in area treatment, do that percolation plus use your landscape to grow more out of the water you have conserved. So that's how the ridge to valley treatment runs. And this runs our concept of entire gamification where we are focusing. So this ridge to valley, you can see the activities. There are only some representative activities. They are all either structures or planting. It's a planting. This is a structure. This is a structure. So either you do some construction or you plant something so that your water slow down and water is recharged into the groundwater. So these are all different types of activities that happen in the Manrega activity to prevent the water from catching a lot of food. So in this context, the planning portal we have developed is named currently as AICTE Dhara. Yukta means planned and Dhara means stream. So under this AICTE Dhara, a planning portal has been built wherein you focus on this small window operation. This is the beginning core of this software wherein you are bringing geoprocessing of what? These kind of layers. You bring the assets from GeoManrega or you bring the asset location from some other associated, because the geotags are inherently available. All of geotags are available. Then the land use, land cover map of that area. Then the roads means adjacency to the roads. So these are all the basic rules that will drive the planning process, so that I will plan entities which are according to scientific rules. Same planning in this initiative, we are thinking of converting into a game, so that people will suggest their own activities and we know what impact it is going to generate. And then all those n number of impacts, when you collect together, what's going to happen to our rural situation. That's the basic line of thought in this entire process. So when you do planning, you have to know what all has been done. For that, we have generated a gridded analytic approach, wherein we are going to put different sizes of grid. Because if you just take locations and try to load it on a map, you just get a jumble of points. You don't make any meaning out of it. So you have to put it in a framework so that the spatial local variations are combined. Here you are looking at a 5 by 5 kilometer grid. They're also generating it 1 by 1 kilometer, 100 by 100 meter. We ask why such staggers? Because all those boxes correspond to more and more local phenomena on the ground. If I stand somewhere, how many assets are around me? This around is defined by this box. And this box also corresponds to many of the satellite imaging, satellite-based modeling processes. So if you want to link what's happening to these assets, with respect to all that, you can gradually join them. So analytics are produced at this scale. Based on these analytics, by excluding where areas are already having assets, planning is being done. One more slightly bit advanced analytics called hotspots. Hotspots means where it is stronger, the phenomena is stronger. Because that strong phenomena, when you go to ground, will actually be intervening into natural resource management perfectly and producing desirable results. So success stories had to be looked into. So in terms of spatial analytics, these hotspots produce that kind of indicator. So put together analytics and planning, we are going to tell that, look, here we are going to do better and better geometry. Then, now when you start getting into the feel of gaming, how this entire gaming is in the context of Manrega. You see, when you say gaming, the basic tenet of gaming, whatever it may be, but especially it is very true in the case of Manrega, wherein most of our players are semi-literates. When they come to it, you should feel that they have got a value out of playing it. So if I am spending 20 minutes, half an hour, 1 hour, by the end of it, I should not feel drained out. I should feel, yes, I have done something and learned something. Then learn the process of planning by practicing, because you are pushing people gradually into planning. In fact, currently in the Manrega process, there is a component called transect walk. When you do a plan, because generally plans are done using a simple concrete surface on which people draw with chalks, mud, stones, etc. They'll place the entities. You might have seen it at many places. That's called participatory planning. So once people draw such plans, those plans are actually compared onto ground reality by walking along. It's called transect walk. So such a transect walk can happen by playing it. So we are going to give an important tool in the hands of villagers where they can play it and they will get absorbed into it and they will understand, okay, if I do this, this is going to happen and I'm going to get benefit. So that entire ROI, return on investment can be just time, should be high. So learn the process by planning, by practicing it. So the game needs to hold the player. It should be either colorful, or it should be music, or it should be a lot of some kind of leaderboards or some kind of remuneration. It has to come back to him. That is a point. Then keep the player rewarded for the good work, but don't push the weak players too much. That means keep on refreshing the board. What happens? Because of the performance is not always same. Anybody who does, even today I'm giving a lecture, it's one performance. The performance may vary on some other day. So when you do that, some people may get pushed down the gaming process. They may not get reward at all. But to keep them rolled in, you have to keep on refreshing the board so that they are rewarded and still others are also into the game. Unless it's like an insurance program, unless everybody contributes to insurance kitty, you will not get a huge insurance bundle. So everybody has to play the game. Then only the game overall becomes powerful. Finally, the unpredictability of the pathways to arrive at the solution. Because whenever you are arriving, you are constructing a check dam, it should be from different types of combinations. Otherwise, or at locations. Otherwise, you will get totally bored. It's all monotony. Every time he comes to play the game, he will be encountering the similar type of process. In the beginning, it is fine, but it should have diversity so that monotony is not induced. I have given one link here, which is a nice link on a very nice article, raccoon.com. He has lucidly explained fundamentals in a very graphically easy manner. With this, if you see tenets, the tenet is actually the pillar. What you have to play on a village canvas with your budget limits given. Because as I told, it's huge money on the national level, but when it percolates down to 6 lakh villages, 2.5 lakh gram panchayats, budget is divided by that number. So you know how much it is coming. So there are constraints on limit. You will create certain set of assets, certain number of assets with that budget constraint. And those assets will be exposed to interplay of biophysical agent. Rain, sunshine, wind, cattle, fungus, growth of plants, trees, weeds, etc. all will interact and they will create an impact out of this particular structure that is done. So this impact should lead to a livelihood enhancement. Check dam constructed, water percolated, groundwater recharge, better agriculture. So enhancement of livelihood happens. Then once this structure is available, it should be maintained over a set of say 20 years, 30 years properly, so that it is continuously yielding the benefit. That's what we are aiming to play here. We are thinking of playing it as a gaming for memory. Then, when we looked at state of Punjab, we have cross India data sets. I just try to look what actually people have done in Punjab over these years in Narega. If you see, it started in 2008-9 in Punjab. Some states have started in 5, 6 or 6, 7, etc. Until date, it is compiled. You see here, you can draw the line at 14. As you know, there was a total policy change, and GIS got attached to Narega, which was what earlier. We have earthen bunding, water absorption trench, mini percolation tank, farm pond, and artificial recharge of well through sand filter as a dominant activity, or even including a check dam. These are the dominant activities that have been happening in Punjab over these years. So this kind of trend actually gives us an insight that these are the dominant activities that are preferred by people as ridge to valley treatment. Ridge to valley treatment means to preserve the water and soil. So you can see up to check dam, you have a consistent performance across all the years. As you come down, assets are not created across all the years, or even if they are constructed, they are at a very low ebb. So 234 urban bunds, 218 watts, 185 mini percolation tanks, 174 pump ponds, 91 recharges, 69 check dams. So like that, the count is available. So this is what has happened in Punjab, because Punjab is a very remote type of situation with respect to Manrega, because Manrega is preferred where there is some level of poverty in villages. Most of the Punjab villages are quite resourceful. It may or may not be preferred, but people may prefer it for some other reason. So out of 261, this table tells only one category called water conservation and water harvest. There are 17 categories activities. In this category, there are 25 subcategories. Out of this, 6 categories got full trend of creation of assets is visible in Punjab. Then, once the assets are created, what impacts we are actually looking to gain? Because this impact is a very critical factor and it is a very micro scale factor. If you see what are the most important ways in rural development scenario, that is Hivre Bazaar, Maharashtra. Please look at these stories. If you see the table, look how between 1991 census and 2011 census, things are totally changed. You see number of BPL families. There are 168 BPL families, which have become just 3 now. Yeah, these are one of the richest villages. Then you see number of duck wells, 97, 284. Number of milk producing cattle is only less than 100. 650 cattle heads are there now. Milk production, 150 liters per day, 3,500 people. Water availability, 1,500 tons, 6,000 tons. They are not given actually increasing the forest cover. I have seen, if you go to Google Earth and put your you can see a nice sequence of forest actually emerging on the hilltop or the hill slope on the southern part of the hill. Please see this because when I met the guy who is behind this, my name is Popatlal Pawar, he said, crisp Hindi, हमारे यहाँ तो एक दारू की बॉटल पे लड़की की शादी हो जाती थी. That was a situation in a village like Hiri Bazar, 400 millimeter rainfall. Now they have become one of the best villages in the world. 2 American universities, one London university, 1 American university are actually putting their studies onto this village to see how rural development is happening. So this is one of the benchmark case. There are several benchmark cases, this is one among them. So this is a type of impact that will happen. Apart from that, there are other sources, like in one of the watershed project what we are studying, we found that the groundwater recharge actually brought prosperity through a check dam. They've constructed it was a study of 1 check dam between 3 farmers in a village called Manigalli, Kollegal Taluk of Chamarajanagar district, Karnataka. After the check dam was constructed, borewell in the farmer's field started yielding more water for 6 to months as compared to earlier 4 to 6 months yield. See, the period for which water is available become more. It means he's definitely going to get more water and more crop. So 3 farmers realize 36,000 more per acre as an additional income. This is a pretty big number for a villager. So this kind of impacts are very clear. There's one more study which actually studied the environmental benefits of Narega across. You can read it comfortably. I leave the slide with you. But as a highlight, see the average crop yields increased by 46 to 100% across districts on crops. In Dhar, MP district, after water conservation and harvesting work, the gross area cultivated increased by 40% to 100%. Means double. It's almost doubled up. The total crop cultivated area has become double at instances. And impact of an area irrigated using surface water. That means in 21 out of 30 villages, the irrigated area increase happened from half to 58 hectares. Means after doing a lot of water conservation through these kind of Narega activities, sea change is happening in the natural resource management. Finally, you see migration of the landless or unskilled laborers has reduced in 29 out of 40 villages by 8 to 100%. So it is a total socio-economic impact what we are looking at, and these have been brought into a virtual setup. This is how we are actually monitoring this. Like we see the pre-treatment image, then the post-treatment image, then the field photos will come from our database. See, stage 1, stage 2 and stage 3 photos are uploaded. So like this, people did work here, they are doing work actually, and the work has resulted into an asset like this. Once the water fills it here, it has its own impact all around. It can feed the water to the crop around, it can recharge the groundwater into system. This all happened, and the details of the asset come like this. The right side you can see the detail of the asset. This is anybody can see. You can go to Bhuvan Manrega and see assets of your village, your own. No need to log in. Okay? But there is some error. This particular work took 843 days to complete. There is some issue, but we are also analyzing these assets like this and trying to give guidance or advice to ministry regarding these things. Another asset, it's a raising of nursery in Karnataka. It's a dry district. Here, you see the nursery has been created, and this is a nursery photo, and it has actually generated enough employment. See, 4,490 rupees it has consumed. There's only one particular problem. You have a lot of heads for spending, so there they are mentioning. So it's slightly anomalous, but yet it has given money for the unskilled laborers. So in 2015, it is completed. So this is how the assets that are available across India are being monitored. This actually gives you a proper visualization to generate a gaming context, because each one entity in this area is a context for gaming. Trees, bunds, soil, buildings, shadows of heights, and erosion, degraded land, trees, all these things, forest. So these are the contextualization entities for preparing the game. So suppose now we'll get into the actual mathematics of doing a spatial game, because I am using the word spatial game. Rift Valley context is a specialized context. There are games which may not be so spatial, but these are typically spatialized. You have a sense of X, Y to it. Suppose let us consume, or let us conceive that our landscape is made up of blocks, because the easy way to construct a volume. Here I constructed a farm pond, so it gets filled now. So filled farm pond, it sends the water below, and these blocks become, they are called base flow. That's called base flow. So these blocks are experiencing the base flow from this farm pond. These grids are assumed to be 1 meter theoretically, because it can be of any grid size, but this is a kind of trade-off. Once it is recharged, groundwater gets recharged from this rural outlet. Additional outflow in April will happen. Dry season it will happen. Now people will grow additional crop. Green is additional crop. So this is ridge, this is valley, water is flowing like this. There's a borewell outlet, the additional outflow will happen in April. And if you see the trend of the entity, you can use this graph and simulate that level. Once the rainfall happens, the water actually is conserved or stored in the farm pond like this, and it will get lost due to evaporation and usage. And the groundwater level, the scales may change or the axis will change. So it will increase during later part of the year. So that's how the groundwater level will calculate. That means while you plan a game or you are looking at a game, there are flow, there are quantities which are essential for putting this Narega into context and bring it into a actual value addition. The additional crop is a real value added here. Compound would have done greening up here also, but true effect has happened once the things come out of this borewell and benefit this crop here. So that's how you are actually conceptualizing a gaming process in a Manrega setup, which is more of a ridge to valley watershed context. Then why Manrega with a gamification becomes a case of ease of business, ease of doing business, ease of engaging? Because once you get into rural community, a gamified planning will be definitely amenable, because if you ask somebody to play game, definitely will come and engage himself, because you're not giving him any lecture or professing. You're trying to make him engaged. Then lot of smartphones. We all know that statistics, you have more smartphones and toilets, etc. That's great. So every time you have smartphones available to people, then the overall wisdom in the village can get into planning faster and with more detail. Because if he's sitting, he will having company, some old person is sitting, 5 people sitting, he will tell do this, whether it will happen, you see. So the flow will happen. Then there are inputs beyond the need of technical language, since entities have their own colloquial meaning. You see, whatever entities you are showing in the game, they have their own meaning already to the people. You need not have to bring technical definition to it. So that's why inputs will happen faster, and people themselves will tell you this is this. Then sense of participation will be strongest for villages. See, I also saw this in one of the publications yesterday in Canada. They use a gamification and found that when you want to solve transboundary issues for watershed management, a gamification will tell people transparently the overall budgeting of the entities you are dealing. So when they participate into the game, they know, yes, we are participating very transparently. If we do that, what will happen to downstream village? If we don't do that, what will happen to downstream village? We will gradually realize. And only better and sufficient data will run gaming process. See, it's a typically different sentence, but better data should come, sufficient data should come into my gaming, so that over a year my game becomes rich. So I want more and more people to play it. When I am able to make them engaged easily, I am getting more data. So that's why the gaming becomes a criticality in such approaches. Then there's a milestone. By now we have lot of imaging, because entire gaming or gamification is about visualizing something into an object. Imaging actually will start telling about so many objects on the ground. You see, we have diversity of Earth observation. Now we have very soon upcoming, every second hour 40-meter resolution, 40-meter blocks of entire India you will get, with its vegetation response, water presence, etc. in multispectral domain, colors. Then if we take Cartosat digital elevation model, you are going to get every 10-meter height of the land surface. So you are getting a digital height surface. Now you can download 30-meter height surface from Bhuvan. Then you have microwave remote sensing of woody biomass, snow, soil moisture. Microwave means you can see either in day or night. You are not using normal light. You are throwing a microwave energy and catching it back. The distance you will convert into the presence of it, and from that you are making a map. Then we are getting every 25th centimeter measurement of the land through Cartosat 3 Indian satellite, Pleiades French satellite. This is the data. Pleiades data is kept on Bhuvan. 2018 period data is that. So 25 centimeter resolution are getting. Then using Planet Lab satellite, which are those satellites, means there are hundreds of satellites, and they will make constellation. 88 of them we have only launched. They will do every year, every day's land cover at 3-meter resolution. That's why I told vegetation. Vegetation definition is very important. And Sentinel data, few of you may be aware, Sentinel satellite, it gives every 5th day 10 to 20-meter land cover, which is amazing. When we started our career, getting 24-meter data once in 20 days was big. That to 21st day is big. That to purchase. Now it's all free download. Then weather, meteorological satellite, every 1 kilometer plus, they are giving every hour weather. Then 3D rainfall. There's one global precipitation measurement mission. You see that website. It's a beautiful satellite. Give you rainfall in 3-dimensional. And microwave sensing of Earth cover every 5th day. Sentinel microwave. This Sentinel above was optical, and this is microwave. Then nighttime lights. That's a satellite's name. Then along with that, we have many ground sensors like terrestrial laser scanner, which can every 8 mm it can prepare a point cloud and give you a beautiful 3-dimensional representation of the objects. So this is how the entire panorama of Earth observation has become very, very strong, which actually feeds to the gaming process. Then, and as I come to the geomantrika and gamification, there is a strong complementarity I am seeing. Complementarity in the sense it actually brings true meaning for activities in the rural ecosystem. When you make a game, people will understand, oh, this means this. This means much more than what we just see as check dam. And the very sufficient instances of success stories of Manrega works are already existing. To see the entire history of soil and water conservation in India, say last 30-40 years, we have enough success stories to tell that, look, when you go and do rural assets, they are actually making impacts like this. And we have wide variety of choices in terms of asset taxonomy. 260 assets you can make. What else you need? You can do several of activities, and that will benefit so many people. Then these things are to be implemented in different agroclimatic contexts. So there is a challenge. Then scientific collation of successes and failures has to happen now. If you don't bring it in database now, having this much of wealth of information and money generation opportunity, we are losing. Finally, when the climate change hits us, we should be resilient. These Manrega assets actually help to do a better planning so that they are in the context of climate change, help to increase the adaptation. Finally, when you have finished the game or you have done a game, it's better to get into the augmented reality modes. This particular image is actually virtual sandbox. You can get it from this particular website. This is one of the real milestone event of augmented reality for ridge to valley planning. You see yourself. It's a very interesting thing. So you can either have these things on a printed village model, means you take a 3D print of your village terrain and try to see the things on that, or you can see it in a virtual thing. It is for this particular virtual sandbox is for the surface hydrology. It will do rain, it will absorb the water, it will synthesize contours, etc. Then you should be able to visualize the outcomes or outputs on a real view shed. Stand on a hilltop, look at the village, where what will happen. That can be got into augmented reality. Then you can do while attribute the assets on the fly itself. You are moving, you look at the asset and it will start showing you the attributes, or you can attribute it. Look, this is this, like that. Then time-lapse augmenting flows on landscape. Because you stand on a hilltop, what are the flows that are happening on the landscape? Flow of water, flow of wind, change of sunlight. These are all affect actually the entire landscape. So you can visualize it in an AR mode. Then these assets will get exposed to all these physical forces and they'll get wear and tear. That also you can visualize through AR. Then visualization of woody crops and their benefits. There is a barren land, plant a plantation virtually, look into time, say grow 15 years the plantation, what will happen you see. Then groundwater, you cannot look inside the earth, but if you have proper AR, you can actually look into the water situation and do a better water budget. By better water budget only, the Hivre Bazaar became such a rich village. In Hivre Bazaar, 80 families came back from migration from Mumbai. And finally, the artificial intelligence, how it gets scoped into this gaming context. Because we have huge amount of geospatial data and process models. They also have rules of impact inherent in them. And you have deep learning, neural nets, part of your machine learning process. And they will tell us about the optimized decision hierarchy and tell these are the outcomes. Just will go through the cloud, input, output, then the game will run. So game will have decreased uncertainty because you are supported by a huge engine behind, and your concurrence for a fail-safe, robust support is very high. 100 people are playing, 1,000 people are playing. Because you have engine running behind, all games are functioning properly. So that is the scope of artificial intelligence that will strengthen our gaming process. And if you use the word holism, Manrega game is a window to holism because it will bring you a holistic development. Because since it's the largest welfare scheme, a lot of people will get involved. Unskilled people will get involved. So definitely there will be a social surge when you use these kind of gaming tools. And gamification ensure that fully agreed upon structures and techniques. Fully agreed upon. I agree, you agree, everybody agrees by the gaming, and that structure will come out. And at Narega level, lot of government projects will get converged. Horticulture, sericulture, fisheries, agriculture, so many projects will converge and they will strengthen the Manrega. So you will have a bunch of activities. And whatever the scheme you are doing is a superset of all natural resource management. 260 is a big number. It's a superset. Automatically, whatever the soil and water conservation you do as RM will already be inherent in our gaming approach. So, in conclusion, these rural development aspects have to be gained, need to be gained more and more for bringing out gap areas of quantifying the process. See, you have to quantify what is happening on rural areas so that you know what money it is generating. And we have a lot of success stories in soil and water conservation. They had to be played upon differing contexts of bioclimate. Hivre Bazaar has to be played in some other context. It has to be played in some other context. So these kind of villages, when they are played in different bioclimate contexts, what will happen? We should understand. Then vast knowledge and data sets coupled with strong data processing abilities will definitely facilitate the top class decision support interacting the virtual landscape. So with this, the gaming will actually strengthen the Manrega process, I believe. And with these words, I will finish my discussion. Thank you for the patient hearing.
My types.
Thank you, Dr. Pujar.
Thank you, sir.
Thanks for sharing useful information. Probably that was a sort of a new insight because we never looked at development from a gamification perspective. So that was altogether a new perspective, and a lot of opportunities could be generated out of this.
Yes.
I'll request the participants to raise any questions or queries.
Hello, sir.
Yeah.
Yeah, I have few questions. One
Kindly
question
identify
is,
yourself. Kindly identify.
my name is Deepak Sharma. I'm from Mumbai, KJ Somaya College of Engineering.
Okay.
Yeah, so we wanted to know whether ISRO is open to collaboration with faculty and students for doing these projects, and will these projects be funded or they will be sponsored by ISRO or some government agency?
It is like this right now because of Corona. Student intake was actually staggered, but ISRO also funds the projects through a program called Respond. Right now, I had to go and attend that meeting. It's on running parallel. You just get onto ISRO website. There's a program called Respond, RESPOND. You can seek funds there. For project students, we don't fund the project students. They can come and do the projects in the campus as part of some mechanisms. We have an outreach division. You can always contact outreach division, and they may nowadays offer virtual projects also. So that's how you can get engaged with any of the ISRO institutes.
Yeah, but these gamification projects also ISRO is open to collaboration?
See, this is the only first gamification project in my domain happening. I don't know about the gamification, other ISRO thing. The capacity building center has to be asked there. Probably that will be open. See, whole ISRO is actually now morphing into a newer reality. So if you wait for another 1.5 months, you will see a lot of things coming out of ISRO. So definitely there will be some scope. Definitely, I will say it will be on a positive side only. Because this word itself is catching up off late, isn't it?
Yeah, can you please share your contact details so that in future we can get in touch with you for more collaborative work?
Sure. Khosla Saab will have all my details. Anyway, because I am part of this program with Khosla Saab, I am sharing my PPT also. So in my PPT it is there. I'll send the mobile number also.
Thank you, sir. Thank you very much.
Professor Deepak, Professor Sharma.
Yes, sir.
In fact, there's a scheme from DST also, not specifically focusing on gamification, but around GIS, they have a division, they support similar projects.
Okay.
Yeah.
Thank you, sir.
Any other question?
Since I'm not a programming guy, they will not ask me questions. Hello? Yeah, please.
Good afternoon, sir.
Yeah.
Hi, this is Irfan here. I'm a doctoral candidate in management.
Oh, great.
So I just want to thank you for your wonderful insights. I could just recall these so since it was related to my job.
You are just like me.
Yeah, I was a program officer for Manrega. I worked with Manrega for 5 years approximately.
Oh, really? That's
yes, I was posted in Kashmir.
So we should be in touch actually.
No, I actually resigned, unfortunately.
But still, wisdom matters.
But still, yes, I'll get your contact details from Arun sir, and we'll be definitely in touch.
You should guide us.
The geotagging, I was part of that program when geotagging was launched in Kashmir. So we took a very active part in geotagging the locations. Actually, that helped.
Where were you posted?
I was first in district Kupwara, and then I was transferred. I worked there for 3 years, and then I was transferred to district Pulwama. I worked in I don't know whether you have heard of this area that's called ATAL. That's in Pulwama district.
I have 15 visits to Kashmir. 4 visits to Leh. Don't worry.
Yeah, but most of the time,
Kashmir a lot.
The part I was in district Kupwara.
Great.
But it was a wonderful experience to work with Manrega. Thank you so much, sir.
Dr. Pujar, I have a question.
Sir.
Are you aware of some similar initiatives being taken elsewhere in the world where gamified has made a difference in this rural development?
सर जो अभी जो शेयर किया इन्होंने मतलब परमप्रीत जो शेयर किया 2 papers, they are actually seminal papers. One is in Canada. I'm forgetting the name. I saw 2 floodplain gaming. We should actually discuss that. They are actually they are one step more They are proving that by gamification, you are actually you are changing the entire psychological management of the watershed stakeholders. It's not about the physics of it or biology of it. It is about the psychology of it.
Great.
It's a very impactful paper. We should discuss about it.
Right, sir.
I quoted that paper, no?
Sir, Irfan here again. Do you work on Manrega? I'm like this area, rural development area.
I am national coordinator for GeoManrega.
Okay.
So I look after entire database day in day out. That's my daily job.
Okay, that's great. I would be happy to work with you if you have
Surely for your master's work, if you want any assistance, any hand holding.
So I'll be happy to contribute. Maybe we can have surveys in Kashmir. So I have all of friends. They are still working as program officers. So I have good connections in almost every block.
Please.
Okay, thank you.
Any other question? Because Dr. Pujar, he has to leave, as he said, he has to join another meeting, a review meeting.
So coincidental. Actually, the presentation there is also on Bridge to Valley Management. We have provided another funding to Vishweshwara Technological University how to look into the watershed modeling of water hydrology, micro hydrology at micro watershed.
All right.
So those findings will be lot useful for our work here.
Okay.
So nice of you. I mean, it's a very clear and very calm presentation ambience. Enjoyed it.
Let's thank Dr. Pujar for sparing his valuable time and sharing sort of a new insights into what gamification can do. Because thanks to Dr. Pujar for initiating this activity, and by virtue of that, we have been associated with this ISRO, and we are getting an opportunity to work in this project with Dr. Pujar. I extend my thanks to Dr. Pujar for his time, for sharing his knowledge, for sharing his insights, and bringing before us a lot of new perspectives. Thank you so much, Dr. Pujar.
Thanks a lot, sir. And people can correspond to me. My email ID is there in the presentation. I will send the PDF. So it will be a pleasure to discuss with all the people. Okay. Bye then, sir.
All right, sir. Thank you so much, sir. Thank you. Take care, sir. So let's pack up today's proceedings, and tomorrow we are going to have 3 sessions instead of 2. The session which could not be scheduled today, couldn't happen today, has been scheduled tomorrow at 3:30 p.m. So in the morning we have 2 sessions, one from Dr. Kathan Shukla from IIM Ahmedabad, and there's another session where the experts would be talking about the unethical perspective of gamification. Okay? Right. Thank you so much.
Thank you, sir.
Okay, sir. Thank you.
All right. Bye-bye.
Thank you, sir. Thank you.
Thank you very much, sir.